Are we live?
Madam, 1 minute, madam.
Okay.
Some network connectivity problem, I believe.
Okay.
And we are live, we can start now.
Linux Laboratories. Live, integrated and excited. Partnering with medical fraternity. Linux is a people and process-oriented global pharmaceutical company celebrating more than a decade of excellence in CNS. Linux offers unmatched value in everything we do to doctors, patients, and caregivers. Linux is a top-ranked CNS company, and today the industry is following us. With persistent effort, Linux spreads its wings in dermatology to make millions look good and feel great, to spread smiles head to toe, to maintain, nourish, and enhance skin health. Introducing the latest, youngest pride of Linux. Linux Derma Science offers endless innovative products like Oxyten, Active MF, BioRite, Acnestol, Protect, BioSkin, Castle, and HiKids. Linux Derma Science needs your care to blossom. Linux Laboratories, Linux Derma Science, live, integrated and excited.
Thank you.
Hello.
Yeah. Thank you. So a very warm welcome to all the members of Nail Society of India and all the delegates who have joined us for this skill-based CME series. Continuing with our NSI skill-based CME series, we have reached on to our third series where we'll be talking about the management of the ingrown toenails. To start the proceedings, I invite Dr. Sushil Tahilaini, sir, who is the President of Nail Society of India, to present his welcome remarks. Sir.
Thanks. I welcome everybody to this third CME, which is a skill-based CME on the management of ingrown nails. Our team at NSI has worked tirelessly to serve this feast. I would say they have made an exceptional program with exceptional choice of topics, and we got best available speakers, both at the national level as well as two international leaders in the subject. And I'm sure you're going to enjoy every moment of this program, and it will be a great learning experience. I welcome you all to this once again. And I'll just give you two more requests. One is that those of you who are not members of Nail Society of India so far, please enroll as members to enjoy more facilities and more benefits. And also, I'm sure you all will know that every year we have a annual UNICOCon. So the much awaited UNICOCon for this year will be a virtual meet in the month of November. You will get an announcement about the same before we end the program. With this, I request the Master of Ceremonies to start with the announcements.
Thank you so much, sir, for your insights. Now to start, we have our first speaker, Dr. Khushbu Mahajan ma'am, who is the Treasurer of Nail Society of India. And she'll be talking about the various causes as well as the pathogenesis involved in the ingrown nails. Dr. Khushbu ma'am.
Thank you. Am I audible, Deepak? My screen is
Yeah, ma'am, you're audible.
Good afternoon, everyone. So to begin the day, we'll just talk briefly about the causes and pathogenesis before we move on to the management. So when we are talking about ingrown toenail, there are two theories, and that is why two names to it. So some people like to call it as ingrown toenail or Unguis incarnatus, whereas few others would like to call it as onychocryptosis, which means hidden nail. Now, the the difference in the opinions about the name lies in the pathogenesis. So there are two theories when we talk about ingrown toenail. Now there is one lobby which believes that ingrown toenail happens because of penetration of the nail fold by nail spicules. So the fault is at the nail end, and the nail spicules penetrate the nail fold, and that leads to ingrown toenail. Whereas there is a other lobby which believes that it is the nail folds which become hypertrophic, and because of the weight bearing, they tend to bulge around the nail, and that leads to ingrown toenail. And so here the nail is pretty normal, and so they like to call it as onychocryptosis, where the nail is being hidden by the hypertrophic nail fold. In fact, there has been a procedure by Van den Bosch. There's a procedure by Van den Bosch which has been described, in which he specifically mentions that while treating an ingrown toenail, we should focus on the hypertrophic nail fold and treat that, rather than thinking about the treatment of the nail plate, which most of us do. So there are two different opinions. However, when we go through the causes, we would realize that both these theories hold true as respect to the causes. So basic mechanisms, why do the ingrown toenail occurs, has been, there have been four basic mechanisms. The first is there is an epidermal break which occurs in the lateral nail fold, and this is because of the constant pressure from the nail plate. The second is the subungual soft tissue which is there, it gets pinched because of repetitive trauma. The third is that there is a widening of the base of distal phalanx, which eventually will cause narrowing and elevation of the distal part of the nail plate. And fourth is that there is a periungual tissue swelling, which eventually leads to inflammatory reaction, fibrosis, and because of this, there is embedding of the lateral part of the nail plate. As we would look at the causes, these different mechanisms play a role in different causative factors. So broadly, what is happening in ingrown toenail? There is a penetration of periungual dermis by its contiguous nail plate. It may be the nail plate which is at fault, or the periungual dermis. Now, whenever this happens, this generates a cascade of reaction. And so there would be some amount of inflammation, pain, redness, and when there is pain, then there would be some foreign body reaction, some infectious process, and that would be followed by some reparative process. But all of these processes, or the cascade of reaction which occurs, would eventually only exacerbate the problem, because whenever there is foreign body reaction or any infection, it would cause more swelling, more embedding, and so mostly we see ingrown toenail as being a more chronic and a cyclical problem. So that brings me to the presentation. So mostly we see a bimodal presentation with ingrown toenail. So there are two age groups which are broadly affected. It's seen mostly in second decade or in elderly age group, which is usually 5th to 6th decade. More commonly feet, we all know, and that too great toenail. And even in great toenail, it is more commonly seen on the distal lateral margin of the nail, because that bears the brunt of weight bearing. So coming to the causes of ingrown toenail, there is no single cause that we can identify in any individual. We have to understand the causes are always multifactorial, and so we have to look at all of them whenever we are dealing with a case of ingrown toenail. So the first and foremost that we all commonly see is improper nail trimming. Now, improper nail trimming would mean that either we are cutting the nail too short, exposing the nail bed, or we are cutting it in a rounded manner or in an angular manner. Whereas a proper cut would be if we cut the nail straight. Now, what happens if you round off the nail? Now, when you tend to round off the nail, there is production of barbs and spicules. More so in a patient who is a patient of ingrown toenail, a patient thinks that it is because of my distal edge of the nail plate, which is impinging on the nail bed, so I'm getting the problem. And so the patient would tend to round off the nail further. This leads to production of barbs and spicules, which goes and anchors into the periungual tissue, and this will penetrate deeper as the nail would grow. And when that happens, it traumatizes the adjacent soft tissue and does lead to ingrown toenail, or the cascade of reaction that happens. Now, this illustrates how a spicule causes indentation into my nail folds and leads to swelling over there, and thus leading to the inflammatory process. The second very important cause is trauma. Now, trauma can be multifactorial. Trauma can be because of ill-fitting footwears, a very tight socks, or various kinds of sports activity that a person engages in. When any of this happens, because of the trauma, there is further constriction of the nail fold into the nail plate, and that leads to further deeper penetration of the existing nail barb. So that is why we also see that ingrown toenail has a very low incidence in barefoot individuals, because all these exacerbating factors which can lead to a blunt or a surreptitious trauma in the nail would not be there in an individual who walks barefoot. Next important cause in a young individual mainly is hyperhidrosis. Now, whenever there is hyperhidrosis, there would be softening of the skin, there would be maceration of the skin, and so the periungual skin integrity would be compromised. Now, when that happens, whenever there is an existing barb or spicule, it would easily penetrate into a softer nail fold. Plus, hyperhidrosis would also increase my chances of having super added bacterial and fungal infection, which would again increase the chances of progression. The next important cause is onychomycosis. Now, a patient who has onychomycosis would tend to have a very hyperkeratotic and brittle nail. Now, this brittleness would in turn lead to crumbling of the nail plate, and this crumbling would in turn lead to formation of nail spicules, which again will progress my disease process. Obesity is another very, very important factor, whether it be young or old. Now, what happens in obese individual is that there is an increased soft tissue that we are seeing in the entire habitus, and that would happen in the lower extremity as well. Now, when there is increased soft tissue in the lower extremity, it will simulate periungual hypertrophy. So this periungual hypertrophy would further be exacerbated because these patients would have a wider gait and a larger habitus. So this would increase the pressure, which will cause trauma and further progress this onychocryptotic process. Now, in older individuals, we have systemic diseases, any kind of systemic diseases like heart disease, diabetes, thyroid disorders, or kidney disorders. Now, all of these disorders we know lead to increased lower extremity edema or pedal edema. And so they will mimic the effect of obesity that we just saw on the nail unit, and thus again increase the chances or increase the progression of ingrown toenail. Talking more specifically about diabetes, because in diabetes there are a lot of other factors which increases the incidence of ingrown toenail in these patients. These factors being poor hygiene, a very decreased frequency of nail cutting. These patients have sensory and autonomic neuropathy, so they have more calluses, they have increased incidence of hammer toes, and they are more prone to different kinds of infections like bacterial and fungal infection. In addition, there is peripheral vascular disease, as we all know in diabetic individuals, and this PVD further increases the nail thickness and disrupts the nail structure. So if we take a diabetic population, we always see that there are increased chances of ingrown toenail that would happen in any diabetic individual. Per se, old age is also a risk factor or a cause. Why? Because in old age, because of the decreased mobility and impaired vision, these individuals will not be able to take care of their nail very well. And per se, because of aging process, we know that there is a thickening of toenails that occurs. Now, both these reasons would lead an old age individual, he would find it more difficult to cut his nails. And so he would be more inclined to exert the pressure on the lateral skin, which is at the sides of the nail plate. And this would again lead to formation of nail spicules and nail barbs. Then there are a lot of intrinsic factors which can be causative for ingrown toenail, like if there is an abnormal shape, if there is a pincer nail in which the nail grows more transversely than longitudinally, thus causing impinging on the nail fold. If a patient has wider nail plate, there is a congenital malalignment, or there is inherent thickening or thinning of the nail plate. Now, in this, I would like to mention specifically about Morton's toe or Morton's foot, in which my second toe is longer than my great toe. Now, when this happens, there is an increased latero-distal pressure that occurs on the hallux nail fold. And now, when you wear a footwear, this pushes against the footwear, and then again it mimics the skin hypertrophy, and thus leading to onychocryptosis. Then there are congenital reasons for ingrown toenail. There have been a few reports of children being born with ingrown toenail or features suggestive of it. This has been postulated because of probably an intrauterine trauma, and there is also hereditary transmission which has been postulated. There has been few reports of twins having this ingrown toenail, and this in children can again manifest in all these forms. There can be hypertrophy of nail fold, or there can be distolateral nail embedding. There can be just a malalignment or overcurvature of the nail plate. There are a lot of medications that we routinely give which can also increase my chances of ingrown toenail. The common ones being indinavir, ritonavir, docetaxel, cyclosporin, isotretinoin, which we use very commonly, oral antifungals, and EGF receptor inhibitors. Here I would like to specifically mention about oral antifungals. Now I talked about onychomycosis, which increases the chance of ingrown toenail. I treat it with oral antifungals, but that in turn again increases the chances of ingrown toenail. Now, why does that happen? Now, oral antifungals normalize the width of the nail distally. Now, this causes impingement on the corners of the distal nail fold, which has already been narrowed, because in onychomycosis, there was a transverse shrinkage of the distal nail bed. Now, this distal nail bed, which shrink transversely, caused my distal nail fold to narrow down. And now, when my nail width is being improved by oral antifungals, it does not fit in. So it kind of again impinges on these lateral nail fold. And so oral antifungals per se can be a cause for ingrown toenail. Before ending, I would like to briefly discuss about Retronychia. Now, Retronychia is a different form of ingrown toenail. Here, what happens is that there is a proximal ingrowth of the nail which happens. So basically, the nail is embedding backward into the proximal nail fold. Unless we know about this condition, it would be very difficult for us to diagnose this. So what is it basically? How does a patient present? So a patient of Retronychia would usually present with persistent paronychia, and there would be some setting of trauma, a repeated insult or repeated trauma. And when we look at the patient, we would see as clinical criteria, there would be some inflammation of the proximal nail fold. There would be some granulation tissue, which would be emerging from the nail fold. And there will be thickening of proximal portion of the nail plate and interruption of nail growth. So here we have to know about the entity to really diagnose it, because otherwise we would keep treating the patient as a patient of chronic paronychia. So briefly talking about the pathogenesis of Retronychia. So what happens in Retronychia is that because of repeated trauma or repeated insult, there is disruption of the longitudinal growth of the nail. Now, when this happens, sometimes it leads to complete separation of the old plate from the nail matrix and the nail bed. Now, a new plate begins to form because the old plate has been separated. Now, this newly formed plate, it will grow under the old one and it will push that old one out. But in Retronychia, the problem is that the new nail is partly anchored to the old one. And so my old one and new nail are both anchored together and they are remaining in the nail pocket. Now, what will happen when the new nail would grow? It would push the old nail upwards, and eventually I will have a multi-layer sandwich of proximal nail which would be there beneath the nail fold. So I will have a new nail plate and an older nail plate on top of it, and these would both be embedding into the proximal nail fold. Now the oldest nail, which is on the top, has a sharp edge, and this will push the ventral aspect of the proximal nail fold and thus pierce its epidermis. So we will be talking about Retronychia management later, but this is in brief about why it happens and what is the pathogenesis behind it. So to conclude my topic, why are we studying it? So when we see a patient of ingrown toenail, usually there are a lot of preventive things that we can offer to the patient. So the surgical management, the medical management does come, but we all know that as it is a chronic and cyclical process, there is a lot of things in prevention which we can advise to these patients. And here come the role of knowing different causes of ingrown toenail and counseling the patient accordingly. Thank you.
Thank you so much, ma'am, for elaborating the various causes and pathogenesis which lies behind ingrown toenail. To take us forward, it is always essential, whenever we are planning a management for ingrown toenail, it is always essential to plan what kind of grading it is occurring, like what kind of grade is there for the ingrown toenail. So to take us forward, I invite Dr. Chander Grover ma'am, who is Professor, Department of Dermatology at University College of Medical Sciences and GTB Hospital. And ma'am is also Honorary Secretary for Nail Society of India. Dr. Chander ma'am.
Thank you, Deepa. Thank you, Khushbu, for making my job easier. In the next 10 minutes, I'll be talking about grading the severity of the condition that Khushbu has so nicely elaborated and planning further management. I bring you greetings from Nail Society of India. And basically with this session, we want you to be able to recognize the spectrum of ingrown nail changes, which have been elaborated by Dr. Khushbu, grading its severity of the different types based on the clinical findings, and choosing an appropriate treatment approach accordingly. The goal being that we should be able to operate on the nail unit with confidence, optimizing outcomes and reducing scarring. So ingrown toenail is a common, tender, unsightly condition which causes frequent functional impairment of the busiest section of the society, let's say the young adults or those in very active lifestyles. It typically predisposes to develop paronychia, and it's a very recalcitrant condition for many of our patients. The types of ingrown based on those so many mechanisms that Dr. Khushbu has told you, based on the nail fold involved, it can be classified as distal lateral ingrown, which is the most common variety. Distal ingrown, proximal ingrown are the other two varieties which we need to recognize more often. So basically, just to say that the nail could be growing into any of the folds, or any of the four folds could be growing over the nail to cause this pathology. There is another way of classifying the types of ingrown based on the age of onset. So we have the neonatal variety where the free nail margin has not yet overgrown the tip of the toe. The infantile variety could be because there is a malalignment of the axis of the nail matrix versus the axis of the nail bed, causing a mismatch when the nail plate grows out. Or it could be a hypertrophic lateral lip or lateral fold of the nail, which is a reversible thing, which is going to reverse over a period of time. The next common age group which is affected is the adolescents, who are most commonly affected by the distal lateral ingrowing variety, primarily because of the types of shoes that they wear, the types of activities they indulge in, and the pattern of cutting their nails, improper cutting. Adult variety is characterized by a sharply bent lateral margin. None of the books mentions the geriatric variety, but Dr. Khushbu has already told you in detail why ingrown, and it does occur more commonly in the old age group as well. You can also classify ingrown toenail based on the direction of growth. So you have the lateral ingrown. Now this is assuming that the plate is the offending factor, the nail plate. So you have the lateral ingrown, you have the distal ingrown, you have the proximal ingrown or retronychia, and you have the pincer nail where the plate is ingrowing into the nail bed itself. So you have the three types of folds and then the bed being affected by the ingrowing of the nail plate. Now, once we know that there are so many types, we need to grade the severity because too many types means too many options. The oldest severity grading and the one which is easiest to understand, and mostly all of us subconsciously are using it also, is the Heifetz grading, which says that stage 1 is when there is pain, which is aggravated on walking or pressing on this particular area, along with minimal inflammation and swelling. So the patient may seem normal to you, but the patient is in pain. Stage 2, when a marked swelling and inflammation has overcome the condition, and there is a non-healing wound and oozing. And such a nail is something which properly causes confusion, whether it is the nail fold at fault or the nail plate at fault. Stage 3, where there is abscess formation, granulation tissue, and the condition has gone on for so long that there is chronic induration of the nail fold. So again, in this condition, you are likely to place the nail fold at fault rather than the nail plate, which appears to be very flat in this particular image that we are showing you. Then came the Mozena classification in 2002, which broke down these stages into one more stage. That is, they broke down stage 2 into stage 2A and 2B. 2A saying that when the hypertrophic nail fold is less than 3 mm, whereas stage 2B, where the hypertrophic nail fold was more than 3 mm. Stage 3 was the one which was characterized by presence of granulation tissue with nail fold hypertrophy. Further clarifications or further refining of this staging was reported in 2007, the Martinez-Nova classification. They maintained stage 1, 2A, 2B, and 3 more or less the same as the previous classification, but they added stage 4, which was a serious chronic deformity of the nail. The difference between 3 and 4 being the site of the distal, the extent of the distal hypertrophy or the distal nail fold hypertrophy. We had another article in 2008, which was further classifying it into stage 5. And the difference here was the authors were taking into account the underlying bony involvement as well. So they took into account the possibility of chronic osteomyelitis also supervening in between. Now, we understand the types, we understand the severity. How do we plan management based on these? So first of all, for planning management, these are the steps that you follow. You acknowledge that there is a particular etiology based on the morphology that you are seeing. Angulus incarnatus versus onychocryptosis, which Dr. Khushbu has very nicely explained. Then you decide the approach based on the severity. So for lesser severe condition, we can spend some time with conservative management, but for more symptomatic patients, you have to move on to the surgical options. The choice in this category is basically across the studies has been seen to be driven by the specialty in which you are working. So podologists and pedicurists generally favor the conservative devices like braces and other similar devices, whereas as dermatologists, most of us will perform surgery, one or the other surgical approach, and depending on the staging that we have come across. So most of these classifications also talked about treatment. We talked about Muzena classification, which said that stage 1 should be treated with conservative management. For 2A and 2B, they asked us to choose between conservative or surgical management, depending on, it's a wide choice, depending on the condition of your patient. So there is nothing hard and fast here. But for stage 3, they are recommending nail fold reduction as well as matricectomy. The Klein staging, the one which had taken into account the possibility of osteomyelitis or periosteitis simultaneously, wanted us to do radiographs or MRI for the cases which with marked involvement, that is anything above stage 3, and with the course of antibiotics, bring that down, stage 4 and stage 5 to be brought down to stage 1, 2, or 3, and then operated or conservatively managed. This is a table which I've taken from a very good article by Dr. Haneke, which summarizes the management of most of the types that we have discussed. Conservative management and expectation for spontaneous healing or with massages is expected to be useful for the neonatal and infantile varieties. For adolescent variety, again, because the condition has been precipitated by improper nail cutting or the lifestyle, conservative management can be worked out with more and more education being given. The other varieties, they have said that you will need, Retronychia will need proximal nail avulsion, and even this is being revisited as of now, as of today. And pincer nail deformity, depending on patient symptoms, needs one or the other surgical management. The aim of conservative management is to protect the nail fold from the distal nail plate, obviating the need for surgery. We'll have Dr. Manas speaking about the conservative management strategies, but broadly they are indicated for early stage onychocryptosis, patients who fear surgery, patients with associated comorbidities whom you don't consider to be good candidates for surgery, patient who is going to be patient, that is, who is going to have a good compliance over a prolonged period of time, and patient with modifiable risk factors for landing up in onychocryptosis. Various conservative measures which we tell to all patients, even if we are doing a surgical management, is advised regarding proper footwear, straight cutting of the nails instead of round cutting, the beautiful diagram Dr. Khushbu had shown, managing the coexisting hyperhidrosis, managing onychomycosis, and soaking the feet in warm water 15 to 20 minutes, followed by application of topical antiseptics. These I'm sorry. There are different approaches which are present in the form of conservative approaches, including taping, packing, gutter, and nail braces. Braces, not most of the dermatologists don't use, but taping, packing, and gutter treatment will be elaborated by Dr. Manas. Surgical management then depends on the stage of the disease. Early stages, you do a conservative approach. Later stages, a definitive surgical procedure. But there is a lack of evidence on ideal surgical procedure because we have so many procedures over so many years being outlined in the literature. So it's easy to get confused as to what should be done. So we have experts from all the fields today telling us about what they find useful so that it can be a weighted approach can be taken. The presence of so many procedures, one thing which we all should keep in mind, and I found this very, very important, so I've just reproduced as it is. The surgery for ingrown should not be a pretty serious one. No one would ever think of removing with an ingrown wisdom tooth the overlying portion of the cheek. Yet that is exactly done to the toe in all reported methods. This was the scenario in 1899, and still we see such extensive surgeries being done in few of our patients, luckily very few. So we should be careful about this. Most authors, Heifetz in his 1937 article had written that most authors fairly uniformly agree on the etiology and symptoms of ingrown toenail. I found this so beautiful, so I'm reproducing it verbatim. It is in the matter of treatment that there has been such uniform disagreement. It is obvious that when one condition has been productive of so many varieties of treatment, probably none has been entirely satisfactory. So we keep looking and reporting for more because we are not happy with one. And each writer, of course, believes his own method to be the best, and probably it is in his own hands. So there is a very important role of what you are conversant with, and you will give best results with that particular procedure. Heifetz had concluded in 1937 that in spite of all that has been written on ingrown toenail in the past, one must admit that there is no concise and generally accepted method of treatment. And in the hands of most surgeons, practically all methods still result with occasional recurrences. Conservative methods require too much time and are frequently ineffective. Incapacitation from surgical treatment is entirely out of proportion to the severity of the lesion. Based on this, what would I conclude my talk today as? The severity of ingrown varies from time to time. So you have to take the patient's symptoms and his level of discomfort into consideration before operating. Even if the inflammation is less, but the patient is too much in discomfort, you have to intervene. Treatment approach is to be planned as per the severity grading. You decide between conservative versus surgical, and you decide between narrowing the nail versus hypertrophic nail fold, or both, keeping in mind the pros and cons of each and every step that you are deciding. Selective matrix horn resection remains the surgery of choice, and this has come out in Cochrane analysis again and again. And this is the advancement that we have over Heifetz's conclusions of 1937. Modality chosen for this matrix horn resection is of secondary importance as per the experience. I thank you all for your kind attention.
Thank you so much, ma'am, for taking us through the various grading scales and beautifully concluding what management strategy to be followed in what kind of severity. Now I would like to invite Dr. Manas Ranjan Puhan, sir. Sir is a dermatologist and dermatosurgeon at Nikki Skincare Clinic, Cuttack. Over to you, sir. Dr. Manas, sir.
Sorry for the inconvenience. So thank you, Dr. Deepa. I think I am audible now.
Yeah, sir, you're audible.
Okay. And I must thank Dr. Chander and Dr. Khushbu for making all these things very easier for me. I don't, there is no need to go for all these details now because already everything has been discussed. So what I am basically going to show you in this my presentation is how to do this gutter splinting method and what are various conservative management. As Madam has said, the best method is to cauterize the matrix. But because once you say that I'm going to do some surgery, I'm going to cut some part of the nail, then really patients are really, they feel something that I'm going for some surgery. So that's a there is a compliance issue. Like patient don't go for they don't want to do any surgery. That's why all these conservative managements are in place, and we do few of the procedures. Rest of the things are being done by you can say beauty parlor or podiatrist or other personnels. So what is ingrown tool? I'm not before going, as ma'am has said, you have to know the matrix. Any surgery on the nail, if you are damaging the matrix, you are going to do some scarring. So that is the only part. Whenever patient comes, that whether I will go for surgery, whether my nail will be damaged, you have to be 100% sure. So that's why the conservative managements have nowadays is more preferred by the patients than the. So these are the causes. So you have to first find out the cause. Already madam has pointed it out. So you have to find the cause. If you know the cause, then go for the treatment. Then only you can prevent recurrences. And always see the grading. If the grade is more than 2, more than 1, 2A or 2B or 3, then always try to go for some medical management like antibiotic and analgesic. Then reduce the grade and go for surgery. So these are the few cases. Even if patients cut properly, you see the good side is having ingrowing. So even sometimes patients have both the sides. In those patients, very difficult to manage with conservative management. But I'll show you with gutter splitting, I have managed few cases. This patient, though she is taking care of the nail properly, but still there is a sinus formation. That means most of the cases you will not find any cause. So you have to go for the treatment. So what are the options? One is general measures, then conservative measures and surgical management. So if there is a proper footwear, proper trimming of the nails, like cutting it straight, then addressing underlying pathogenic factors like hyperhidrosis and if there is a fungal infection, as madam has said, warm water soaks, cleaning with hydrogen peroxide, iodine and silver nitrate application, all these things will help in the initial phase. This is very important. Whatever method we do, this part is very important, like how to cut the nails properly. If you are cutting it properly, it will prevent recurrence. That means it has to be cut only in the straight line. It should not be in the U or V shape. Otherwise, you are bound to get recurrences. So what are the non-surgical or conservative methods we are having? So tapping is the best one. Then we have packing. We can use a dental floss to, so basic aim is to remove the embedding or ingrowing nail. So you can, whatever method you do to widening the nail, and the nail plate should not enter the soft tissue. You can use a toe spacer, then nail brushes, splints. There are some angle correction technique, like you have to thin out the top of the nail plate, then the gutter splinting, and there are some newer techniques. So this is one of the method you can make them understand, like patients can use. You just try them, they will understand. You instruct them, put the cotton twig under the nail and repeat it, like every alternate day or every day you have to change it. Patient has to use a forceps, remove the cotton and put a newer one. So gradually go on increasing the amount of cotton. So within 2 weeks, there will be a clear space between the nail plate and the soft tissue. In the tapping method, here we are preventing the soft tissue to obstruct the nail growth. So the band-aid should be started, should be placed, it should be started in the distal end. Then gradually by putting a pressure towards lateral side, then towards back. So the pressure should be like that. The lateral nail fold should stay away from the nail plate. So this is one method can be used very in the lower grade, like grade 1 patients, they improve a lot. But 2-3 things we have to use the correct band-aid. You can give them Dynaplast, that is best one, or band-aid can be used at the Johnson band-aid. And before doing this, the area should be dry, because otherwise the wet tissue will not hold these bandages. This type of dental wear you can use, so that you can make, you have to make 2 holes, and then the nail, the pincer type of nail is best treated by this method. So you will gradually flatten the nail plate. These type of instruments are available in the Amazon. You can keep it with yourself, or you can advise the patient so that they can use by themselves. So, basically, I will be discussing about this gutter splinting, because most of the as a dermatologist, we don't do all these procedures. But if you can advise the patient so that they can do it's better. This gutter splitting method, how I do, these are the photographs I'll show. Then I'm going to the video directly. So, is it visible? The video is visible, Deepa?
Yeah, so that is.
Okay. So, so this patient, though it is here there is little bit of granulation tissue. If there is no granulation tissue, then you can go for without putting a xylocaine. So directly you can go for, you can put some topical anesthesia for 2 hours, then remove little bit of granulation tissue and put the plastic tube. But because this patient is having, and I am doing for the demonstration purpose, so I have injected and use the plastic tube, proper plastic tube. If you are using a very soft plastic tube, then you will not get, there will be no such that much space will not be created between nail plate and soft tissue. So you use a semi-rigid or little bit hard tube. The best one is you can use the cover of the Venflon. So that is the best one. This tube I have taken from the pathology department. They use this tube in the semi-automatic analyzer where they do thyroid and other tests. So, and you have to bevel at one end, then cut along the length, make it a, like a gutter. I'm going to use the same tube for both the nails. That's why I'm making for both the sides. So this is how you do. You can use a surgical blade also for this, and this can be easily sterilized. You can go for chemical sterilization for this plastic tube. Now it is ready. So now I'll go for the. So here I am going to remove the extra granulation tissue little bit. Otherwise, it is not needed. If it is a very lower grade, then there is no need. I am just seeing how much the nail is there, and the nail should be little bit strong for this procedure. If nail is already broken, then you cannot put the plastic tube in place. So now I'll show you how to insert that one. So here I'm just removing the excess granulation tissue. And most important thing is here, the patient should be counseled enough, like to keep the plastic tube for about 2 to 3 weeks. Because though within 1 week we are getting good result, but those who keep for 2 to 3 weeks, the recurrence rate is very less. So I've just removed the granulation tissue. I'm just going little. So this is how the tube is placed. So you have to insert the tube. Sorry. So you have to insert the tube, then cut along a little bit at 3 to 6 millimeter distance from the soft tissue. So initially I was cutting just at the angle, and the granulation tissue used to overgrow. So if you cut little bit distance, then there will be no such problem. Then just put a light bandage, putting some extra gauze. This is how it is placed. So you can just measure the thing, cut it beforehand, and make it ready. Then you can insert. Here in this patient, I need to give some antibiotics because I have made some injury. Otherwise, in other patients where there is no such granulation tissue, you can directly put without removing that granulation tissue. Other side, I am showing the same way I have done. So now this is how this tube is placed. I am showing here because I faced in this patient. See, I was trying to push it, but it's not going because
Manas sir.
I think there is a network issue. We have lost him temporarily.
Yeah, but the whole screen has got blank.
Yeah, mine too once. Dr. Deepak, maybe we can move on to the next speaker, Dr. Vineet, till Dr. Manas joins us back.
Sure, ma'am. Sure, ma'am. So we'll wait for Manas sir, and probably when he joins back, we can again invite him to continue the video. In the meanwhile, I'd like to invite Dr. Vineet Relhan sir. Sir is a professor, Department of Dermatology, Maulana Azad Medical College, and sir is also the Vice President for Nail Society of India. Vineet sir.
Yeah, thank you so much, Deepak. I also joined just in time. Yeah, I'll share my screen. Is it visible?
Yes, sir, it is.
I'm audible also?
Yes, sir, you're audible.
Yeah, so I'd be talking about ingrown nail surgery with chemical matricectomy. So that is a very commonly performed procedure by all nail surgeons. And most of the things about the ingrown toenail, the etiology, and about the grading have already been covered in the previous talks. So I'll just go straight to the topic. So this is the classification which Dr. Chander has already discussed in quite a few details, and Mosena classifications which we generally follow have also been covered. So generally the surgery is done in stage 2, 3, 4. Stage 1, generally we do conservative management, and that is a very recurrent one. So what are the complications of ingrown toenails? You can get paronychia or secondary infection of the nail folds. That is very common. The scarring of the nail folds, skin, and rarely cellulitis and osteomyelitis can occur. And in diabetes, there is always a risk of amputations or life-threatening infections. The surgical interventions are done. The indications for surgeries in ingrown toenail are the patient has pain and functional disability. There is recurrent ingrown toenails or onychocryptosis. There is a surgical relapse when the conservative treatments have failed, and moderate to severe stages of ingrown nails, that is 2 to 2, 3, 4. And the surgical intervention, the aim is to remove the ingrown part of the nail plate partially along its length, and the partial destruction of the matrix of the corresponding area of the nail removed. That is the most important thing. If you are going to remove only that part of the nail plate, the chances of recurrences are to the tune of 70 to 80% unless you destroy the matrix, whether it by chemical or by surgical procedures. So destruction of the lateral horns of the matrix, that is called the lateral matricectomy, is an essential component of the management of ingrown toenails. This procedure will relieve the patient of the symptoms and prevent the regrowth of the nail in the same direction. And it leads to cosmetic and functional acceptable nail structure. Now the surgical techniques can be the excision of the spicule and partial matricectomy, that is a Suppan 1 technique. So you move the matricectomy with a blade or a curette. These are the commonly performed ones are the chemical partial matricectomies. You remove the partial nail plate and destroy the matrix by chemical like phenol 88%, sodium hydroxide 10%, or trichloroacetic acid 100%, which are the commonly used ones. Nowadays, you can use radiofrequency matricectomy and laser, CO2 laser matricectomy also, which we'll be discussing in the later lectures. The wedge resection and total matricectomy are not done these days. So chemical partial matricectomy gives results, the relapse is very less, around 4 to 5% cases only. Now, contraindication to the surgeries, there is no absolute contraindications. Peripheral vascular disease, cardiovascular disease, uncontrolled diabetes mellitus, disorders of hemostasis, acute infection or inflammation of the nail unit, and allergy to the anesthetic agents are the relative contraindications for the procedure. Now, lateral nail avulsion and phenolization, the preoperative for this, the surgeries are, you take a detailed history and examination, history of diabetes, any bleeding disorders, peripheral vascular disease, cardiovascular disease, ask whether the patient is on non-steroidal anti-inflammatory drugs, blood thinners. If the patient is, then you stop it for 5 to 6 days prior to the surgery. Discontinue smoking prior to the surgery. Take a detailed informed consent. The instruments required are the nail spatula, English nail splitter. You require these are the toothpicks. These are the toothpicks for the phenolization process. This is phenol, and some people use the sodium hydroxide and chloroacetic acid. We'll discuss in details later on. So as with all nail surgeries, you need to give a proximal digital block, or a distal block is also good enough, but I prefer a proximal digital block. The procedure, the various steps are, before we go to the video, are we prepare the toe and feet with povidone iodine painted at least twice. Give a proximal digital block with 2% lignocaine. Distal block can also be given. Tourniquet is very important. The good hemostasis and good anesthesia in nail surgeries will reduce your task by half. Surgical glove can be used. Roller cotton gauze, Foley's catheter, Penrose drain. We have covered all this detail in the last CME. Then the lateral 20 to 25% of the ingrown nail site is for the avulsion part. That means roughly 2 to 3 millimeter of the nail strip is removed. The partial avulsion of the lateral nail plate is done to remove the full length of the ingrown nail plate sliver. Then you can use, depending on the chemical you are using, I frequently use 88% phenol. Some people use sodium hydroxide or TCA. 88% phenol is applied directly to the matrix. I use it 3 times for 30 seconds, 30 seconds to 1 minute each round. The people have reported good results with 1 minute also. Then neutralize this excessive 88% phenol with saline, betadine, or 70% isopropyl alcohol. Now, in cases of grade 3 ingrown toenails, there will be a lot of granulation tissue on the lateral nail fold. So do radiofrequency ablation, electric cautery, or CO2 laser, whatever is available with you, and a bulky dressing, which is essential for all nail surgeries. Now, this is a pictorial representation. This is grade 3 ingrown toenail. We have a lot of granulation tissue on the lateral margins. So I have cut the nail plate. This is a full nail sliver gone, around 2 to 3 millimeter or 20 to 25%. Phenolize with 88% phenol for 1 minute. Then neutralize this with betadine, and this is the result, but it had ingrown on both the sides. So the nail plate is very less amount of nail plate is there, but the nail folds are now absolutely perfect. Now, what about the post-operative dressing? That is important part in the ingrown nail surgeries. You apply post-surgical pressure with sterile gauze for 5 to 10 minutes, secure hemostasis. Then a bulky non-adherent dressing. First layer should be of paraffin tulle, petrolatum coated gauze, then cover with a bulky dressing. Secure with a roller gauze or elastic bandage. Or white dressing, which has been recently described, can also be done. Elevation and splinting of the fingers or foot and elevation for 1 to 2 days is recommended to reduce pain and edema. And dressing should be changed after 1 to 2 days and later after 1 week under aseptic conditions. Antibiotics and analgesics for 5 to 7 days. So if the surgery is clean, there is no granulation tissue, I rarely give antibiotics, oral antibiotics. Analgesics I give for 4 to 5 days. This was the white dressing which I was talking about. Now, what can be the complications we can expect from the surgery? Pain and swelling is there. Post-operative oozing for maybe up to 4 to 6 weeks with 88% phenol. With sodium hydroxide maybe less, and with TCA also less. Delayed healing, tissue necrosis can be there. Chemical burns. The phenol can cause chemical burns, as well as there could be alkali burns with sodium hydroxide, and infection, which is quite rare. Now, there are different types of chemicals which can be used for chemical matricectomy. Phenol, it is commonest use, 88%. Generally 3 rounds of 1 minute each round, or 1 minute has also been reported good results. High success rates of 90%, and recurrence is just to the tune of 5%. Low, the disadvantage could be pain. Post-operative oozing for 4 to 6 weeks can also be there. Chemical burns and tissue necrosis. Sometimes systemic toxicity by absorption. Sodium hydroxide concentration used is 10%. 3 seconds to 3 minutes is the duration of application, but 1 minute is fine enough. Success rate is 95%, rapid healing and no systemic toxicity. Article published by Dr. Chander Grover in IJDVL. It's a comparative study with phenol, and it states that pain is less, there is definitely less postoperative drainage, and the tissue necrosis is less, so healing time is much more better. But only thing is that less studies have been done with sodium hydroxide, so phenol is used quite frequently. Trichloroacetic acid, 100%, also good results, 95%. The restriction is relatively less as compared to phenol, and it had been studied, but it is not a double-blind study by Dr. Umit Rosin from Turkey. Now, coming on to the video demonstration, this is one of the cases. Sorry. So, antiseptic, you clean with betadine the toe which has to be operated, and other toes also, at least twice. This is very important step. Then, as with all nail surgeries, give a good anesthesia. So, proximal digital block is the best one. Insert around 1.5 to 2 ml of lignocaine on both the sides. This is a medial aspect, and then on the lateral aspect, in between the toe space. But important thing is wait for 10 to 15 minutes after giving this block. It takes time for the digit to be anesthetized, and our young postgraduate students are in a very big hurry to go about it. They don't wait, and then they land up with a digital block also, digital pin block. A good tourniquet, so I am using the glove tourniquet. The appropriate size finger has been cut. Proper exsanguination is very important. So start from the distal end, go up to the proximal end. See, it has been very good blanching has been achieved. So good hemostasis is very important. Insert the nail spatula and just rotate it in a clockwise direction. This lateral horn has been exposed with the nail splitter. Cut through the nail totally. So this is 2 to 3 mm of this is enough. And this lateral gutter which is formed, curate it if there is some crust or minor granulation tissues there. This is 88% phenol. We have applied inside through the lateral gutter to target the lateral horn matrix. Keep it there for 1 minute, or what I frequently do is vigorously rub for 30 seconds in 3 cycles. Now the excess phenol has to be neutralized, so I do it with flush it with the normal saline, and in few cases I do use a betadine to neutralize it, and a good bulky dressing. But important thing is please keep the tip end of the toe exposed so that you can see after 2 days whether there is some bluish discoloration or not. If there is, then it is need to worry, or ask the patient if there is excessive pain, should report to you immediately. So post-operative analgesia, you can give antibiotics if required. If there is a lot of granulation tissue, you have done a lot of electrocautery or radiofrequency. But normally cases of grade 1 or 2A may not require the antibiotics post-operatively. This is another video. Again, a lot of good antiseptic cleaning with betadine, and do it on all the toes. Then digital block, proximal digital block on both the sides. Wait for 10 to 15 minutes. Tourniquet, proper examination is very important. Then use a nail spatula to clear the lateral nail folds, and the proximal nail fold in the area you want to do the excision of the nail plate. Insert the nail spatula beneath the nail plate and separate it from the nail from the nail bed, and cut through with the nail splitter. This around 2 to 3 mm or around 20. This lateral horn is there. It would roughly be 20 to 25% of the nail plate. Yeah. This should be a full cutting, and then use a cotton tip applicator tube with 88% phenol. So this is so nice. This is no granulation tissue on the bed is there, nail bed is there, and the nail folds are also clear. And insert it for 1 minute. Do a vigorous rubbing, that is important. And later on neutralize with normal saline or betadine. So it is quite a relatively easy procedure to perform, and the results are quite good. The relapse rates are very less, around 5%, 3 to 5%, depending on you have done the procedure. Thank you so much.
Thank you so much, sir, for very informative videos demonstrating the chemical matricectomy. I think Dr. Manas sir has joined back. Manas sir?
Yeah, I've joined.
So can you please...
okay, so I'll be... So I think... so now it is... My screen is visible?
Yes, sir, it is visible.
Okay, so I've almost finished the video part. So I'll be showing some photographs, like the serial photographs, how I do. So you have to see the lateral plate, then put the plastic tube in place, the way I was showing in the video. So, and after 1 week, it will look like this, or you can say after 2 to 3 weeks, so you'll have a good nail. And then the most important part is cutting of the nails. If you give them proper instruction how to cut the nails, this will prevent recurrence. This is applicable whatever method you do, whether you do some surgical method or conservative method. These are few other patients. Another patient I'm showing. So you can use the plastic tube of the that saline IV set. Another few patient. Here I'm showing, like if you cut it very near the soft tissue, then you might end up with overgrowth of granulation tissue. So that's why it should be little far away. The way I have done in this, I have given a comparison. So you have to put little bit longer the tube, and you should not use very soft tube, otherwise your purpose will not be solved. So the best way is this one, but you can procure any type of plastic tube, sterilize it properly, then you can use it. This one is plentifully available in any ward. So some of the pre and post photographs, these are the patients difficult to treat because both the sides, but still I tried to manage it with this plastic tube. And Dr. Khushbu has already explained this one. I wanted to show that reverse onychocryptosis is something you should keep in mind, or there might be two parts in the ingrowing toenail. One, there might be another ingrowing in proximal part. In that case, you should not try this gutter splinting method. So how to differentiate, all those things were discussed, but only thing is if you put a pressure from the lateral side, you will feel pain in case of Retronychia, whereas in typical onychocryptosis, the pain is if you put the pressure from the distal end. So in that way, you will know. So to conclude this, considering slow recurrence rate and reimbursement, it can be an effective and non-invasive first-line treatment modality. You can reduce the grade by giving some antibiotics or some other major antibiotic analgesic. Then you go for the conservative management or this gutter splinting technique. And again, sorry for the technical glitches. So thank you all.
Yeah, thank you so much, sir. So since you have talked about the conservative management, there is a question for you. Dr. Ram Malkani wants to know, For geriatric population, any urea creams available for softening the nail plate?
Yeah, you can use for the softening of the nail plate, you can use 40% urea, and it can be used in a combination with white soap paraffin and other things. But 40% urea, you have to keep it overnight or around 48 hours. Then only the nail will soften and it can be easily removed.
Thank you so much, sir. Now moving ahead, from chemical matricectomy to radiofrequency matricectomy, I would like to invite none other than Dr. Archana Singal, ma'am. Ma'am is Director Professor, Department of Dermatology at University College of Medical Sciences and GTB Hospital. And ma'am was also the founder president for the Nail Society of India. Dr. Archana, ma'am. Ma'am, your screen is visible.
Ma'am is muted, I think.
Now, is my screen visible?
Yes, ma'am, it is visible.
Okay, so thank you very much, and I really congratulate Dr. Tahiliani and Dr. Chander Grover and other team members for putting up a brilliant series of this skill-based CME. So I'll be talking, a lot has been said about the etiology, about the classification, and the surgical management. I'll be talking about the radiofrequency matricectomy for ingrown toenail. I declare no conflict of interest. There will be a lot of, there has to be a lot of overlapping of the information. I'm sure the audience won't mind it. So ingrown toenail is a common disorder of the big toe. It is characterized by pain, swelling, and discharge, but it carries a significant negative impact on the quality of life in all age groups. As we have discussed earlier, majority of grade 1, if we go by Heifetz classification, can be managed conservatively. For rest, surgical intervention is required. And these are the candidates for ingrown toenail, high heel, and narrow front where there is no room even for the boys, which puts lateral pressure on the big toe especially, and the improper cutting or trimming of the toenails are mostly responsible for occurrence of ingrown toenail. The grades of severity, Heifetz 1, 2, and 3. So approach to the management includes general measures, which is common to all. That means proper trimming, open footwear or broad footwear from the front, soaking into the lukewarm water for 10 to 20 minutes every day, and antibiotic cream. The medical or the conservative management for grade 1 includes gutter splinting, strapping, taping, dental floss, nail braces. I'm very, very fond of Dynaplast taping, and it has given me some wonderful results in grade 1. And that's how I do it. I don't use tape, otherwise Handyplast, etc., because the grip is not that great with them, and it usually lasts, if you put it with Dynaplast, it usually lasts for about 2 to 3 days, and let the nail grow out. If there is distal embedding of the nail, then you can put Dynaplast from here also. For grade 2 and grade 3, surgical management is required, and the simple thing is to do is partial nail avulsion with lateral horn matricectomy, which is common to all procedure. Now, how it can be done? The matricectomy can be done by chemical means, by radiofrequency ablation, or by CO2 laser ablation. I think Dr. Soni will take laser ablation. Chemical, as we have learned from Dr. Vineet Relhan in great details, can be done by 88% phenol, 100% TCA, or 10% potassium sodium hydroxide. But what are the problems with phenol matricectomy? The problem is during the procedure and after the procedure. What are the problems during the procedure? It's a blind procedure. When you are doing it for 1 minute, for 20 seconds each time, there is tracking of phenol towards the contralateral side of the nail matrix as well. And also on that side, how much phenol will go, it's very difficult to standardize that and rationalize that. And sometimes there is unintended application surrounding nail fold also. So it takes long time to heal. After the procedure, there is prolonged oozing, which can continue for 1 week. And sometime I have seen that it continues for 2 to 3 weeks. So there is longer downtime, and patient getting back to work in the busy schedule these days gets almost impossible. So what we do with RF matricectomy is that I have been practicing for grade 1, recurrent grade 1 when it recurs, and all grade 2. It's less messy and it's very clean. There is significantly less downtime. There are less visits to the hospital, only once when patient comes for the procedure and once for the changing the dressing on after 48 to 72 hours. And then patient is on his own. And patient gets back to work much early. The RF ablation, one has to be very sure that it cannot be performed in a patient who has got cardiac pacemaker installed. So these are the little instruments you require. The nail splitter, the nail plate elevator, there is forceps. And then I use this machine, we have it in our hospital. This is a monopolar, this thing, and the power setting is between 2.5 max, which gives me cut and coagulation mode simultaneously. So there is no bleed, nothing doing. And this is the angled probe that can be used, but you can also use narrow straight probe as well, whatever is available. So this was a 17-year-old girl who complained of painful toe for more than 2 years. And as many people have, Dr. Khushbu and other speakers have elaborated, that the patient feels that since it is hurting in the nail is hurting my surrounding tissue, so they cut it, and see how bizarre, she has cut her nail plate and there is granulation tissue. So there is, it's clear cut grade 2. And there is history of nail avulsion without matricectomy. So it had been done twice by a surgeon and an orthopedic surgeon. And she had, her quality of life was very much disturbed. So you can, I'm not going how the anesthesia is done and how the tourniquet, I have placed gauze tourniquet. I am separating the nail fold from the underlying nail plate, and I am detaching the lateral nail plate with the nail plate elevator. And you can see this is the lateral horn of the nail matrix, this triangular. And since she's already chopped the nail splitter, so I am taking around 1 to 2 millimeter distally, and I'm just getting rid of the lateral horn of the nail matrix. So this is a triangular, so one has to be very thorough with the anatomy. And we remove this part. This is triangular part because the distal part was already removed, and there is formation of this gutter, as Dr. Vineet also. And now I am exploring that if there are any remnants of the tissue or the remnants of the lateral horn of the nail matrix which are left, so that have to be removed. As you can see, the tourniquet is very much appropriately placed and there is no blood. So it has to be a bloodless surgical field since the field is already very small. So once there is a lateral nail plate of the nail matrix has been avulsed, I'm using this cautery with the monopolar this thing. And since I know that the lateral horn of the nail matrix is here, so I'm destroying it. I'm take around 2 to 3 seconds of application. And I do it 2 to 3 times, and my end point is when I feeling that charred smell, burning smell of the tissue. So that's how when I do it. So in another video to show you the setting of 2.5, and you have to use the saline soaked gauze piece when you do cauterize it with the, I'm doing it for the second time. And now I'm placing the probe right there. You know, it is also a blind procedure, but I'm doing it mainly with the pressure downwards so that I'm not hurting or I'm not cauterizing the nail fold on the, which is lying above the, and 2 times or at the most 3 times is sufficient. You can guess what if you required, and see there is no oozing, there is no unlike phenol, there is no tracking down of the phenol lotion onto the other side or in the surrounding nail fold. So it's a very clean and not messy at all. And now I've done for grade 3 also. And once you are done, see, it's absolutely neat, and you put the liberal amount of antibiotic ointment. I use mupirocin ointment, and then you use the non-sticky the gauze, this thing, you put the paraffin gauze piece, and you do the bulky dressing as has been suggested by the previous speaker, Dr. Vineet Relhan, as well. And you can, once, because you have removed the tourniquet, there may be some bleed, so it is always good to put the foot in a higher position, so that in an anti-gravity position. So what are the post-procedural advice? Limb elevation, as we do it for all kind of matricectomy, whether chemical, systemic antibiotics can be given, may not be given, depending on, these are the rainy season, I prefer to give analgesics for the first 2 days, that's all. And then SOS is usually not required. Change of dressing, first dressing after 48 to 72 hours. And thereafter, the patient changes the dressing on his own, because there is no ooze following RF matricectomy. It's very important to give advice about the footwear. Even whenever I ask patient to come for matricectomy, I ask them to use V-shaped footwear, V-shaped chappal, so that, with bulky dressing, it is possible to wear the footwear. And advice regarding proper trimming of the growing nails. You can call patient after a week or 2. And these are the still photographs when I'm using the angled probe after matricectomy, and that's how, and there are certain results. After 2 days, you can have slight necrosis, and day 7 and day 14. So patient can actually start going to work after day 2. Another this thing, and we published our findings in the Journal of Cutaneous and Aesthetic Surgery. And this is another one. So RF ablation, radiofrequency, I always say they're poor man lasers. The technique is much faster, it's less painful, it causes selective tissue damage, it does not, we can prevent the damage to the surrounding tissue. There is less lateral heat spread and tissue damage, faster healing, better control, and I haven't seen the recurrences so far. So thank you very much for your patience.
Thank you so much, ma'am, for such an informative videos and such an innovative procedure beyond chemical matricectomy. Ma'am, there is one question which Ashwani Modi has asked. He has not specified the procedure, but he has written, in spite of doing the procedure exactly as mentioned, I am seeing recurrences in adolescents. What can be the reason?
I think the lateral horn matricectomy was not done properly, because otherwise whatever may be the recurrence should not happen. So whether it is chemical matricectomy or it's RF matricectomy, it has to be done. So I think one should be thorough with the anatomy to know where the lateral horn of the matrix lies. And post-procedural footwear and advice on the trimming of the nail is very essential.
Thank you, ma'am.
Yeah. Hi, Bertrand.
Hello.
Good to see you.
For joining so late.
So moving ahead from chemical matricectomy to RF matricectomy, we now move to the laser matricectomy. And for that, I invite Dr. Soni Nanda, ma'am. Ma'am is a consultant dermatologist at Shine and Skin Clinic, Mayur Vihar. Dr. Soni ma'am.
Yeah, so Deepak, I've shared the video. Dr. Chander would be playing the video. Is she there?
Yes, ma'am.
Yes, I'm there. I'm sharing.
Right.
Is it audible?
No, we can't see it, Chander.
It's not visible yet?
Your screen is visible, ma'am, but the video is not yet shared.
Okay, just 1 second. I'll share it again. Is it visible now?
No.
Is it? No.
The screen is visible, Chander, but I think maybe you need to click on that again, the video.
Just 1 second, I'll share again. So
Otherwise,
it's playing at my end, and
should I try to share it? Now we can see it.
Yeah, it's visible now.
And while sharing the video, you need to select the sound box and video optimize clip. There's 2 boxes. While sharing the video, the sound is not coming.
Sound is not coming yet.
Just stop your share screen and try again.
But Soni can talk, no, live.
So share sound and optimize for video clip.
Yes, and then select your video and play.
Right.
At the outset, I would like to thank the Nail Society of India for giving.
Now is it audible?
Yeah, it's
audible, ma'am. Yes.
This opportunity. Now let's understand few key characteristics of a carbon dioxide laser. CO2 laser emits light in the infrared region with a wavelength of 10,600. The chromophore is water. The mechanism of action is by selective photothermolysis, and essentially it is photothermal in action. CO2 laser was the first laser which was used for skin resurfacing. The major challenge being to cut the tissue in less than 1 millisecond, which is the thermal relaxation time of 20 to 30 micrometers of skin, which we expect to be targeted with a beam of CO2. A unique feature of CO2 laser is that when you ablate an area of 20 micrometers, 3 to 4 times this area gets ablated. There is always a residual damage of around 0.5 to 1 millimeters. This is very important that you keep it in mind when you are working with this laser. For our nail surgeries, we use the continuous wave. In this wave, the thermal damage is more. So it is important to use the optimum energy, a low pulse duration, and a small spot size. But the good thing is that even your conventional CO2 laser would do. You do not need the fractionated mode. For matricectomy, we have the time-tested phenol, we have sodium hydroxide, radiofrequency. All of this has been demonstrated and we know all of this works. So why do we need a laser? Laser gives us very good precision. We exactly know how much area we are damaging. We can reach the lateral horns and vaporize the lateral nail fold both. The hemostasis is excellent, so we get a bloodless field, and it is very fast. Also, when we are using this laser on skin, we are scared of post-inflammatory hyperpigmentation, which is not the case in nail surgeries. On the contrary, the residual coagulation damage which happens is helpful in proper destruction of the lateral nail fold matrix, which really helps in decreasing the recurrences post our surgery. So now let's see where all our CO2 laser can be used for ingrown nail surgeries. CO2 laser has been used in ingrown nail surgeries since the 1980s. It has been used for cutting of nail, for vaporization of the granulation tissue wherever required, and for matricectomy, both in the lateral horns and the lateral nail fold. Laser comes with two modes, the general mode and the fractional mode. General mode is what we use. The probes for the general mode which are used in skin surgeries are these, which have a large focal length. This is a 50 mm and a 100 mm probe. What I prefer for nail surgeries is this probe, which is used for oral surgeries or the dental surgery. In this, the focal length is less and the spot size is 0.5 mm. So it is very easy to get into small areas like the lateral horn when you are doing the matricectomy. Also, it is very easy to focus the beam and also defocus the beam. Now, once you have attached the probe, you go to the general mode, and continuous wave is the preferred mode of the laser when we are using it in areas which are highly vascular. For matricectomy, an energy of anywhere between 2 to 3 watts is enough. Some authors have tried using the methylene blue dye to demarcate the matrix and then see if they are able to destroy it completely. For cutting of the nail, 3 watt might not be enough. So in that, we start with 5 watt and we can go up to 10 watt depending on the thickness of the nail. When you are cutting the nail, it is advisable not to do sawing of the nail and try to get a clean cut. Cutting nail with laser has the advantage of giving you a very clear edge and a good shape of the nail post the procedure. Doing matricectomy with the laser, it helps you because the laser coagulates the small vessels very easily, so you get a bloodless feed. The operative time is decreased significantly. There is no post-op oozing. Laser also sterilizes the area, so you do not need post-op antibiotics. And since there is no oozing, the recovery time is very fast. So the patient can get back to work over a matter of 5 to 7 days. Also, you do not need much of painkillers because the sensory nerves, they get blocked to some extent by the laser. Now let's see how the procedure is actually done. For using the CO2 laser for your ingrown nail surgery, you should avoid using spirit as it is inflammable. Clean the area only with povidone iodine. Use a wet gauze instead of dry gauze because dry gauze can catch fire. You will need to make sure that your nail is closer to your laser. But in this laser, if your laser has an articulated arm, then it becomes very easy to reach any areas. When you are using a small probe, it becomes easy to focus the laser. So you need a focus beam when you are cutting and you want to defocus the beam when you are doing matricectomy. Also, when you are able to destroy the lateral horns properly, the rate of recurrence goes down from a 37.5% to a 6.2%, which is a significant improvement in your laser results. When we are doing area like nail, continuous wave is the preferred mode because it's a highly vascular area. Also, do keep in mind that CO2 laser is a class 4 laser. Any laser with an output of more than 500 milliwatts is a class 4 laser. In this, it is absolutely essential that everybody in the room wears glasses. For the operator, you get these special glasses which are meant for this wavelength of 10600 because the eyes can get damaged both due to the incident light and the reflectance of the light. Also, since the mechanism of action is vaporization, lot of fumes are produced and viruses, bacteria, they can survive in these fumes. So it is important to have a good smoke evacuation system in your laser room. So you can have a machine like this and make sure that you use it while you are doing your surgeries. And another very important question which I think needs an answer is that, is it worth buying a CO2 laser for doing your nail surgeries? In most of the cases, except if you are into exclusive nail practice, it might not be worth. But most of us, we end up buying a CO2 laser for our other skin procedures. And when you are buying it, you can ask for a dental probe or an oral surgery probe. It does not cost anything extra. And you can use this laser very effectively for your nail surgeries and hence reduce the post-operative time and also your time of the operation for the patient significantly by using the laser. Thank you.
Thank you so much, ma'am, for the new and innovative technique of doing the matricectomy. There's one question for you. Dr. Sushil Tahilaini sir wants to ask, do you reflect the proximal nail fold for more accurate and complete CO2 ablation?
No, sir, it's not required to reflect the proximal nail fold if you have a small probe. If we are using the conventional probe, which we use for our skin procedures, then we will need to reflect. But with this oral surgery probe or the dental probe, we can just go in the space as Dr. Archana showed with the radio frequency, and we are able to damage the matrix easily.
Okay, ma'am. There's another question by Dr. Ashish Om Prakash Mehta. Can we do the procedure in pregnant females 2-month ANC?
So per se, I don't think there is any contraindication, but for lasers, generally first trimester, it's better if you can avoid. So better to use your chemical matricectomy means there.
Okay, thank you so much, ma'am. So moving ahead, now we'll move on to the...
Even chemical matricectomy with phenol will not be safe in this scenario which has been talked about. So maybe we can discuss it more during the panel discussion. And absolutely, if it has to be done, because granulation tissue and PG, pyogenic granuloma formation, can per se the outcomes of pregnancy. So first it has to be...
TCA will be a safest option.
Yes.
So per se, there is no contraindication to fractional CO2 also. But generally, with pregnancy, if you've used a laser, then at times it might become difficult for you to justify the same to the patient. So better to be safe with a TCA.
Yeah, thank you, ma'am. There are some questions from the delegates which have been asked after the talks. Like we have moved ahead, so they will be taken again in the panel discussion. So moving ahead, moving on to the nail fold surgeries. Now I would like to invite Dr. Bertrand Richert, who is the head of the department, Brugman St. Piers and Children's University Hospital. And he's also the professor of dermatology at University Libre de Brussels at Belgium. He's also served as the past president for the Nail Council of Nail Disorders. Dr. Richert, over to you. You are not audible, Dr. Richert.
Okay, can you hear me now?
Sorry yeah, now you're audible.
I was muted. So about the surgery of the nail fold, we know that there are a lot of surgery can be done. And what is interesting for us today is ingrowing nails. So we're going to talk about surgery for ingrowing nails on the lateral folds and on the distal fold. This is really indicated when you have hypertrophic soft tissue and distal embedding. So you will not work on the nail, you will work on the amount of soft tissue and you reduce it permanently. So it's a surgery without matricectomy. So a large volume of soft tissue can be removed just really to decompress the nail plate. Of course, you will reduce thus the inflammation. And as you will be not working on the nail plate, neither on the matrix, there is no risk of spicule formation at all. Oops. First surgery we're going to talk will be debulking with suturing the defect. And for that, we have two procedures, the Howard-Dubois procedure and the Noel procedure. Let's start with the Howard-Dubois. This Howard-Dubois removes a crescent of flesh at the tip of the finger. You see that this nail is really sinking into the soft tissue, and well, it's ingrown for years and years. There's no more granulation tissue. It's chronic type. And what we're going to do is remove a wedge of flesh to pull down this normal skin and free the nail. So this is how it goes with slides. This is the wedge removed. And then when you suture it down, you see that the nail is reappearing. And this is the procedure that you're going to see. Oops, it's not working. My video is not working. Okay, let's pass the video. I hope my videos will work. So from here to here, and this is the scar at the end of the after several months, and you see that the guy has the scar running around the nail, and you have this nail which looks completely normal. It has not been narrowed like with other procedures. Here we are working on the soft tissue. Of course, it's there is some pain, and you have to give good painkillers. The second type of debulking with suturing the defect is the so-called Noel procedures. It's a procedure that was invented by Swiss dermatologic surgeon whose name was Noel, which in French means Christmas. And he was also inventing this technique to avoid touching or narrowing the nail. So you are removing, it's a Dubois indeed, but it's a vertical one, it's not a horizontal one, and you do that on both sides of the nail unit. So I'm going to show you that with other pictures. So you're going to remove two lateral wedge, and then you're going to suture it back. So all the excess tissue will be gone. So this is a girl, she's 12 years old, terrible ingrown nail for years and years. And you see that if you're going to perform finalization, she will get a very narrow nail. And she's a teenager. So what we have done is, you see this nail is again disappearing into the soft tissue. So that's the two wedge. And you have to be very deep. You have to go skimming the bone, skimming the nail, really up to the pulp. So it has to be very deep. And then you suture it back like this, very easy, not too tight. So you see that the excess tissue has disappeared. The nail has come back to a normal size that was prior to the ingrowing. And this is the result after 8 months. So she has a complete normal nail, and she has no sequelae, no onycholysis, no spicules. So this is very, very interesting as a technique. That's another one. And that's another one. So you see that for this chronic hypertrophic soft tissue, it works very nicely. Now we can also do debulking with secondary intention healing without suturing. And that comes to two other procedures, the so-called Van den Bosch procedure and the Super U. Let's start with the Van den Bosch procedure. It was invented indeed by a military surgeon, and he wanted his guy to work properly, and he decided that he was going to remove all the excess tissue and let it heal by secondary intention, because they had to work fast. So it was invented in the 60s, as you can see, and it was put back on stage by a Canadian guy, which was Dr. Chapersky, and really he showed a lot of cases because this technique was completely forgotten by a lot of doctors. And the thing is that you're going to debulk very, very generously on the side, as you can see. And the most important point is you are leaving this part of flesh attached. So I would say the median third of the pulp and hyponicum has to be left there. Why? Because when you remove the whole thing, you may have some traction, which might be painful for the patient when after healing, because the hyponychium is pulled down. So this will help to avoid that. So you're going to really debulk. You see, you expose the nail very, very generously. And that's the problem of the beginner. You remove not enough soft tissue. So I hope this video will work. And all my videos are not working. I'm sorry, but they were working on my computer 10 minutes ago. So it's a pity. So what you do is you just excise the whole soft tissue. As I showed you very generously, you leave here a little piece of hyponychium, and this is what you get after 6 weeks. Of course, it takes time. You need to ask the patient and show the patient how to do the dressing. And usually post-operatively, just to avoid the bleeding, I just place a running lock suture just for hemostatic purposes. That was another one that I guess will not work either. Okay, that's, I guess it's your platform. And well, this is how it goes. Look, 1, 2, 3, 4. This guy has been operated like 20 times for the last 10 years. And he was really worried, and he didn't go to the beach anymore. He didn't have any more girlfriend because of these really ugly nails. So this is the debulking. You see, it's very, very generous. You see that the nail has reappeared completely. And you see here the running suture just for hemostatic purposes. And this is the guy after 6 months. You see, he has complete normal nails, a little scar that would just disappear there. The nail is going out nicely, the corner is out, and he will be free forever. Another case, you see, you have to be very generous. The problem of the beginner is they cut not enough. It has to be generous. And this is what you get after 6 months. This is, you see, he came back from the beach, you see some sand, there is no scar and a complete normal nail. So that's very important when it's only hypertrophic tissue from chronic ingrowing. This is a case of one of my fellow, Dr. Marie Cocanas from France. And what is amazing, she did this wide excision. She left this triangle there. And you see that it looks like a really small nail. But if you look closely, you see that the nail starts over here because the pathologist was cutting and cutting and cutting in the corner. But you see that the size of the nail is this. And this is after a few weeks. So you see the secondary intention healing. And this is, again, a little bit later. And you see that the nail has come back to a normal size. The cuticle is back. Well, that's the two scars from the incisions. And this is the result after 6 weeks. And this is after more than 1 year. You see that he has complete normal nail. And for that, it's a really, really good technique. Otherwise, if you would have done phenolization, he would have had a very small remaining nail. Now you can also perform the Super U, which was invented by Ival Perez Rosa. He's a Brazilian derm surgeon, and for his PhD, he invented this technique. So it's the same as the Van den Bos. So it's a wide debulking, and he called it Super U because it's like a U around the tip of the toe. And you see that he is not leaving this little triangle. So you may get some trouble if you are too generous on the hyponychium. Remember that the ingrowing is mainly occurring on the lateral side. So be generous on the lateral side and be maybe less generous on the hyponychium. And this is what you can get from terrible ingrowing nails, like you see with hypertrophic soft tissue, inflamed soft tissue, and here you have no scar, on the contrary of the Van den Bos, because he's starting here on the side, and you see this guy has complete normal nail. So this was a video too of Superu, so it's not working. And this is a little girl, and she had like also like 12 surgeries with phenolization, laser, whatever. And she always had this terrible hypertrophic soft tissue. So I decided that that I should do something different. And I went for this very wide debulking on the lateral side. You see that this is my running suture or locked running suture all over. And you see that I have been very generous and that the nail is fully exposed. And this is the result after 1 year. And she had no recurrence since then. So you see, and you don't see any scar, because the mother, when she saw these little sausages on the toes of her daughter, she was not very happy. And I said, you will see nothing. And this is the result. So it's very, very nice. And also you can combine technique if you want, because, well, when you look here, this is a very hypertrophic soft tissue with, of course, granulomatous tissue. And when I have done this debulking, I see that the nail has a very wide curve and there is over curvature. So what I've decided is I'm going to couple it with phenolization. So I removed a strip of nail and did the phenolization, and this is what you get after 1 year. So I've treated the excess soft tissue, but at the same time, I have cured the over curvature and the too wide nail. And then you have something that just comes back to a nail that doesn't even look to have been operated. It looks to a complete normal nail. So, of course, for this kind of surgery, especially if you are doing secondary intention healing, you have to know about how to manage bleeding, because that's the main side effect of the surgery. This is the only complication you may have, because it's a very easy surgery. You just put your blade on the nail plate and you just cut away what is overgrowing. So it's very, very easy surgery. So you can use different things. Here, my friend Milton DiCacchio, you see, he has a running log suture here that you can see. And underneath this hemostatic foam. I love hemostatic foam. It helps you very much. It comes in various sizes and shapes. So you can just cut it and adapt it to put it on your wound. And the thing which is also very, very important is to use some what I call volumetric tourniquet. It means once your surgery is done and when it's bleeding, then you have to re-inject whatever you want. You can inject some anesthetic, long-lasting anesthetic, which is interesting in this condition, or you can also inject just saline if you want, and you just inject it here. Why here? Because you know the anatomy of your vessels, and you know that the digital artery is coming here and is giving 3 arcades in the nail unit. And of course, this is the from a dissection. This is here that you have to inject an amount of liquid just to be sure that you're going to press a little bit on the digital artery and that the blood will just stop immediately. The bleeding will stop immediately. It's fantastic. And my take-home message is that aggressive debulking for hypertrophic soft tissue is something which is extremely easy. There is no risk of spicules because you're not working on the matrix, so no risk at all, no risk of dystrophy. It gives very satisfying cosmetic result, whether you're using suturing or not. Of course, the prerequisite is that you should have a good knowledge of bleeding management. And you can imagine, because you're either pulling on the soft tissue or you're cutting a lot of soft tissue, there may be traction. So you have to give potent painkillers for about 2 to 3 days. And of course, you have to inform your patient that secondary intention healing is a long process. It may take from 4 to 6 weeks, but amazingly, it doesn't leave any scar. And if you want to know more, I would recommend you to have a look at this book that I committed with friends of mine, and it's only on the management of ingrained toenail. And I thank you for your attention.
Thank you so much, Dr. Bertrand Richert. Just 2 words: courageous surgeries, and I think incredible results, as can be seen from your presentation. Moving ahead, for the management of Retronychia, I would like to invite Dr. Michela Starace. She is an assistant professor, dermatologist at the Department of Specialized Experimental and Diagnostic Medicine, IRCCS, Policlinico Sant Orsola Alma Mater Studorium, University of Bologna, Italy. She's also the secretary for the European Nail Society, and she's a board member of IDS. Dr. Michela Starace.
Thank you, Dr. Deepak. Dr. Michela has not been able to join us, but she had sent her presentation, and I'll be sharing that right now. And hopefully she joins us by the time of this panel discussion. That is what she has just written in the mail. 1 second, I'll start sharing my screen again. So visible?
Yeah, it's visible.
So hopefully, yes, and
this is my disclosure. I have no conflict of interest.
It's audible?
It's audible, ma'am.
Yes, thank you. How come it's not audible now?
Now it's not audible, ma'am.
I don't know what happened.
Ma'am, you need to play the slides again.
I will do that again. I'm sharing. Share sound optimized for video clip. Audible now?
Not audible, ma'am.
No.
I'm share from the first slide.
Retronychia today is not a so rare disease.
Now it is audible.
Audible.
Yeah.
Retronychia today is not a so rare disease, and a lot of publications start to appear on the literature about this disease that start to publish in the 2008. But as you can see in these pictures, we can have a lot of publication in the years, and we published recently 2 important papers about the use of treatment in this disease, nail disease. But in the first papers, first of all, they describe the pathogenesis of this nail disease. And together with the bowline, with the onychomyiasis, they are grouped especially in one sense, so the trauma, that induce on the basis of the severity of the trauma, we can have the different sign on the nail unit. With these very nice painters of Professor Piraccini, we can describe the typical alteration that induce at the end the formation of a retronychia. We have, first of all, a trauma that induces an onychomyiasis and repeated insult on the distal margin induce the detachment of the proximal part and an interruption of the alignment between the matrix and the nail plate. This continued trauma arrested the nail growth that are detached on the proximal part, and for this reason you can see onychomyiasis or onycholysis. Then a new nail start to grow, and there is this proximal ingrown of the nail plate, and on the basis of this new nail grow, the number of a new nail grow, we can have a severity of the inflammation, and in the later stage we have also the presence of pyogenic granuloma, and this is worsened on the different trauma that continue to have on this digit. As you can see in this clinical picture on the lateral view, where you can see the typical detached part of the proximal due to the presence on the proximal nail fold of different layer of the nail plate, and then you can see here a new nail that is well represented in this picture. As you can see here, the typical Retronychia and the detachment of the nail plate in this digit. The typical aspect of Retronychia is in adolescent and young adult, especially in female than in male, especially in this type of person that continually perform sports where there is a lot of jump, so like volley, basket, and so on. Usually one or both the big thorn. On the clinical aspect, the typical sign of a Retronychia is an acute Retronychia with or without the presence of pyogenic granuloma, and this depends on the basis. This is on the severity of the disease. Then we have a yellow nail plate due to the detached to the nail bed, and then the arrested nail growth. You can see another typical aspect in severe stage, the second grade. You can see here for the presence of a pyogenic granuloma or granulation tissue that is typical of later stage. And here another example of bilateral Retronychia. You can see here the pyogenic granuloma and the typical Retronychia in the both digital nails. Trigger factor are first of all insult, minor or repeated, as you can see in the volley, in the basket, is very typical of this adolescent. Sometimes it's possible to know an acute insult that start the formation and the formation of the nail disease. It's possible to have a systemic disease, or also it is typical of nervous anorexia. But another anatomic aspect that can be a factor of the development of Retronychia is a lateral deviation of the first toenail. This is considered the only predisposing factor of Retronychia. General, on the clinical, we can have different manifestation, different degree of the manifestation, with the severity of the chronic Retronychia, the presence or not of pyogenic granuloma, the detachment of the nail plate due to the presence of yellow nail, and then the arrested nail growth. But in all cases, the pain is the symptoms reported by all the patients. And you can see the typical aspect in another example in a severe stage. And here, another example. Onychomadesis can be evident at the beginning or during the formation, the formation of the Retronychia. And you can see in this case on the proximal, you can see here the detachment of the proximal nail plate. Then sometimes very, very evident, as in this case, it is upper the proximal nail fold. Here you can see another example. It's very, very typical. After the onychomadesis, the onycholysis starts proximally and may progress distally or not. It depends on the basis of the detachment of the nail plate to the nail bed. And then the onycholysis, you can see here, may progress again, and then they are completely come out, they are completely detached if there is a big trauma. Onycholysis may persist and make the nail plate susceptible to back and forth movements that damage the nail matrix. It is very typical. Due to this movement, they completely detached. As you can see, after this nail avulsion, you can see a completely cover of the proximal nail fold. So we have, first of all, an arrested nail growth, then due to a trauma, a repeated or acute trauma. Then we have the onychomadesis. Then we move to the proximal onycholysis, and then a new nail starts to grow one by one below the old one. You can see here there is a big trauma that arrested the nail growth that remain attached on the nail plate, but a new nail started to grow because there is not a cicatricial event, and they started to cover one by one in the proximal part. Then you can see here the diagnosis is on the basis of the typical clinical manifestation, but in a very doubtful case, you can use the ultrasound, that is a non-invasive method to evaluate the typical presence of the two or more overlapping nail plate. Moreover, there is a decreased distance between the root of the nail plate and the base of the distal phalanx, especially at the level of the distal interphalangeal joint. And in addition, we have a decreased echogenicity of the proximal ungual and the proximal nail bed due to the inflammation and the onycholysis, very typical. Some differential diagnoses can be selected as infection, tumors, psoriasis, drugs, but the clinical aspect and the history of the patient is very useful and is very direct for management. That is the most important aspect, is the early recognizer of the disease, because this recognized permit avoiding full development of Retronychia that usually in severe case require a nail plate avulsion. So nail plate avulsion is typical of this aspect with a severe, as you can see in this picture, we completed the touch of the proximal nail plate. We remove the nail plate. You can see here a very perfect find of the nail bed, completely clear and clean. And then there is the follow-up after 1 month, after 6 months, with a completely regrow of a new nail. But this is another example with the complete nail plate avulsion, you can see here, and then the follow-up, another one here, the nail avulsion, and a completely recover after a few months from the nail plate avulsion. And is another example, you can see after 6 months with a complete recovery of the nail plate. It is possible also to have difficult cases, as you can see, very severe degree, but with a very great result after the surgery. And another one after 6 months after the surgery. In 30% of cases, it is possible to have at the end a nail dystrophy. It's not so rare, but it's important to follow the patient over time. But the real question is, can we avoid nail avulsion? It is possible to not arrive in nail plate avulsion. That is possible to have this side effect after the surgery. Yes, it's possible, because if you recognize the disease in early stages, Retronychia may be cured, avoid nail avulsion. And it is easy to recognize because we have the arrested nail growth and mild periungual inflammation. As you can see in these cases, it's very easy because the arrested nail growth, it is very easy to recognize because the patient tells it that he never cut the nail plate for a lot of time and the cuticle are lacking. So it's easy to understand also together the history of the patient. Here another, and it is possible to look at with the height magnification, the typical initial development of the proximal onycholysis may be evident. So the goals of the treatment, in case to avoid the surgical treatment, is to decrease the inflammation of the proximal nail fold and to remove the unbending of the proximal nail plate. And the last, we have to increase the nail growth rate. For this reason, we have to, first of all, to decrease the inflammation. So the real goal is the use of steroid. You can use different methods, so the topical or intralesional steroid. And we recently published this very important paper where we create a an intermediate stage of the typical, the classical early and late stage, where we put the intralesional steroid as the gold standard method to avoid the nail plate avulsion. So in the early stage, we can use the topical steroid. In intermediate stage, we have to use the intralesional. In the late stage, we can we have to arrive to perform nail avulsion. This is very important. Usually, the topical steroid is recently published by Lancaster et al. With all of us contribute to this paper with the use of topical steroid in high potency topical steroid on the proximal nail fold with a great result in this early stage, especially also under occlusion, to try to arrive on the proximal nail fold and to arrest the progression of retronychia. In intermediate stage, we can have the use of intralesional steroid on the proximal nail fold. The typical local side effect can be hypopigmentation and focal atrophy. But the result of the use of intralesional is very good. We have the paronychia, the proximal nail fold elevation and discharge, and the nail plate discoloration decrease in a significant way. And also, the arrested nail growth statistically improve after the completion of the second injection. So, very, very good result with this technique. Another possibility is to remove the embending of the proximal nail fold in the proximal nail plate. And this is, we have only the mechanical avulsion. This is an example of the proximal detachment of the nail plate. You can see after the mechanical avulsion. And again, another example with a great result of a new nail growth after 1 month. And this is another example. So another possibly side effect after the avulsion or in general of retronychia is the formation of hypertrophic distal nail fold, and we have to avoid this after with especially the taping. This is a very Japanese technique where we completely with an important stretch we try to put under the hypertrophic pulp and try to avoid to create a barrier during the growth of the new nail. In the early stage, another important is to increase the nail matrix growth. We use the association of a systemic vitamin A with a high dosage together with the application of 5% minoxidil solution on the proximal nail fold. We have to try to use this technique for 6-12 months. And you can see here some an example with a very good result with the use of this technique. At the end, we published recently a publication that we start with the different method and algorithm. Finally, we describe an algorithm on the basis of the severity of the disease, the evolution that can be various on the basis of the type of the patients, adult versus adolescent, because the activity is different on the age of the patient, and also the hobbies that is typical of the patient, as you can see, volley versus normal jumping, or maybe a sedentary life. And we can select on the basis of the patient the treatment invasiveness, and on the basis of this choice we can have the different outcome and then the different sequela you can see. And at the end we create this treatment algorithm that after the review all over the literature, and we select on the basis of the symptoms reported by the patient and the severity of the stage, and at the end we can have different complications. First of all, the formation of a distal nail fold and the granular tissue, and we can select the therapy, the right therapy, on the basis of all these factors that are very important to select the right therapy and understand which is the sequela of each therapy and of each patient. So at the end, recognize of the early stages may prevent full development of Retronychia and avoid the nail avulsion. This is very important. You can recognize with the typical presence of arrested nail growth, lack of the cuticle, and the presence of onychomadesis. So try the medical therapy if you have the possibility to see the patient in the early stage or intermediate stage, but you have to arrive to surgery in a late stage. But in this case, follow the patient to avoid to arrive in the surgical therapy. And thank you for your attention.
Thank you for the video, Dr. Starace. So moving ahead, we'll start with the last talk of this day. And for that, I'd like to invite Dr. Sushil Tahilaini, sir, who is the president of Nail Society of India. And sir will be talking about the management of pincer nail. Dr. Sushil Tahilaini, sir.
So, thanks. It's a tough job to do, but I'm sure we had two very important topics covered very well. Now I'll talk about the pincer nails. And we know the transverse over curvature of the nails, which typically increases from the proximal to distal, is called pincer nails, which gradually pinches the nail bed, which you can see to the extreme over here. It's quite frequent on the toes, but rare on the fingers. And you can see the pincer nails affecting the great toe as well as the other toes, and not necessarily in a hereditary, even in acquired, you can see multiple nails. And it can be mild, or it can be so severe that the two edges of the nail plate touch each other to form a complete circle. And I don't know how to manage these, so I'm going to ask one question to Dr. Bertrand Richert about advanced cases management. And it can be on both the sides, and it can be, in this case, as you see, not on the great toe, but second toe, and it can be on one edge with acute angulation or incurvature. So this is called plicated nail. Uncommon, you can have over curvature, which does not increase. So you can have the thing which moves parallel to the two edges and not converging. So it could be hereditary or it could be acquired. And of course, it has been described with Kawasaki's use of beta blockers, heavy fistula, which is done for the renal failure cases for hemodialysis. But the most common causes are the deformities of the feet with deviation of the phalanges due to ill-fitting footwear or osteoarthritis of distal interphalangeal joints. And here is to understand that when it is osteoarthritis is most common, there's an expansion of the base of the distal phalanx, and the nail matrix is attached to distal phalanx with the collagen, which has got the strength of a ligament. So even that gets expanded and it reduces its curvature. And because of which there's an over curvature of the distal end. And once it overcurves on the distal end, the sole horn of the nail plate is attached to the tip of the distal phalanx. Again with the collagen, which is with a ligament-like power. So there is a traction on the bone, and which causes development of a traction osteophyte, which is called a dorsal distal traction osteophyte. So where do you treat? Because the patient may have pain, there you see inflammation, patients may find it difficult to trim the nails, or there could be aesthetic indications, and when they wear shoes, there could be pain because of wearing shoes in presence of the pincer nail because of pressure on the edges. And it could be conservative treatment in mild cases where people try the use of, you create grooves in the center, or you could use 40% urea, or you could use a diamond burr and thin the central part. As the nail plate becomes thinner, it becomes more malleable, so this can stretch out. But they say conservative treatment does not keep into account the fact that there might be osteophyte down, and plus they say the time it takes to achieve an improvement, in less than that much time it usually recurs once you stop the treatment. Likewise, there are braces, both the metal braces which can be tightened periodically, or plastic elastic braces which are glued to the nail plate and which gradually open it up. But surgical treatment is characterized by principle of what you've seen already, permanent removal of the lateral nail matrix ons, and it by itself is sufficiently effective. But in case you see a distal osteophyte growing, you have to supplement it by laterally expanding the pinched nail bed and cutting the distal dorsal traction osteophyte. So that means after having done the first part, which you've seen in the previous presentations, where you do lateral partial nail plate avulsion and then you put phenol, or you could use radiofrequency, etc. Then you separate and cut the part of the nail plate which is practically at the junction of the matrix to the nail bed, though it may be difficult to see in a thickened discolored nail. And then you take an inverted T incision. Some people take only a vertical incision and then they separate the nail bed from the bone on either side, and they pull it from either side and expose the bony spur, which is then either trimmed with a rongeur, or you could use a diamond burr and smoothen it. But what I found easy for a beginner like me was, you take an inverted T, which is modification of technique. You go just beyond the hyponychium and extend the incision on either side and take it this way, inverted T, and then you take these flaps away and expose the bone and trim it. And then you put the two things back and close it with absorbable sutures 50 or 60 or non-absorbable. And after that you do either an acrylic nail or some donor nail, but not the nail that you've removed because that is overcurved, or you just put paraffin gauze 2 layers and fix it with a dressing. So I'll just show you. You do the digital block, you achieve hemostasis, you do the vertical partial nail plate avulsion and chemical matricectomy, transverse nail plate avulsion, which I showed you, inverted T incision of the nail bed, removal of the dorsally protruding osteophyte, and incision sites are resutured and dressed. This is a modification of Haneke technique, and this is a modification suggested by Jung Dong from Korea. So this is a patient of mine. As you can see, the pincer nail, the front view, and I would rush through this because this part has been seen already, that you do a partial nail plate avulsion. So let's go to the next one. So having done so, then you separate the, so I'm clumsy, but it takes time because it's not very easy accessible because of the bone that is protruding. And then you cut it from the sides using the nail splitter, the English anvil nail splitter. And this is what I showed you. And then you do the inverted T. And here the bone is protruding, so it's not very easy. It's uneven surface, and you have to remember, as I told you, that this nail bed is firmly attached to the bone, and that's why the osteophyte is created. So we have to be tentative so that we don't overdo it. So here you see, ultimately, I have managed to separate the two sides. And here you see the two folds which are reflected and the bone is exposed. And then I have used the diamond burr because we are more comfortable using a diamond burr to trim the osteophyte. It is believed that you're supposed to put cold saline, otherwise the heat that you generate can cause necrosis of the bone, and therefore we don't overdo it. And it's easier seen in the video, but you have to remember to reflect the nail bed and do it adequately and not overdo it. And then you smoothen and then you put the two folds back and suture it to put the inverted T back with absorbable 50 or 60. Either you can use Vicryl or you can use monocryl. And this is the same patient 1 year later. Once the patients do well, they are lost to follow up. So I had to trace the patient. And once I'll show you the results, pre and post treatment, it's fairly gratifying. With that, I come to the end of this demonstration. I'll just go to the previous slide to tell you what, in an advanced case, Dr. Haneke and Dr. Richert, Bertrand Richert and all do. They, after having smoothened the bone, they put a suture in the lateral nail folds. You put it from here and put a rubber tubing underneath and take it behind and then tie it up and keep it for 3 weeks. So that way you will be expanding the nail bed. But as Dr. Dong Jung has shown, without having pulled it, if it is very constricted, you do that. Otherwise, having removed the burr, the bed gets flattened and it gets expanded automatically. Thank you.
Thank you so much, sir, for discussing the various management techniques for the pincer nail. Now we move ahead for the panel discussion, which is a case-based discussion being moderated by Dr. Chander Grover, ma'am. Over to you, ma'am.
Thank you, Deepak. Is my screen visible?
Yes, ma'am.
Yeah. Now we'll start with the final part of this session, a case-based discussion, because we think that it works best that we take it case-wise and then share our learnings from the cases. Panelists for the day are all the speakers who have graced us till now. Dr. Michela has still not joined us. I would request all the panelists to please put their cameras on and their audios. And the session outline is basically in the form of a freewheeling discussion on day-to-day cases with clinical details being provided with a representative image. And then we'll take inputs from the panelists as to what they would want to do in this case. So I request our audience to please keep on sharing your questions in the chat box. It'll reach us and we'll be taking them up case by case as and when you want to, as and when you have specific queries in the mind. The goal is to encourage optimum treatment planning and execution for management of ingrown toenail, which is one of the most frequent nail disorders in the young, especially even in the old age group, producing a negative influence on daily activities and causing significant discomfort and pain to up to even 2% of the population. There is only one study which said that the prevalence is possibly even 2%. The treatment descriptions are available since 1,000 years or so, and we had discussed initially in the first 2 talks by me and Khushbu. As of today, we have broad categorization into the conservative methods as well as the surgical methods, but the good news is we have potential for cure. So all this is not without the silver lining. All the discussion that we are doing is aimed at cure, not just at temporary relief. So the first case will be a 19-year-old lady who complains of pain in the medial distal end of the lateral nail fold, which is present off and on. So she has pain and she doesn't have pain at times. As you can see, there is no swelling, but there is a distinctive cut because of her way of cutting her nails. But the pain could be elicited on pressure. And she says that cutting her nails short relieves her pain. So my question to my panelists is, what will you do? What will you recommend for this particular patient who does not have very significant signs, though she has symptoms off and on?
I think I'll ask her to soak her feet with whatever little inflammation she has tenderness. That means there is some inflammation. So she'll soak her feet every day in lukewarm water, soapy water. And then I'll be happy doing dynaplast taping on the medial side.
On the medial side, the taping which is to be taken, ma'am, would you like to tell us about the taping in detail?
I had shown the picture because it should be of the length of the whole length of the nail plate and 1 or 2 millimeter extra. And then it has to go around on the plantar aspect of the big toe. And it should be, the force should be high enough to separate the nail plate from the lateral nail fold.
So the fold
and yeah, Dynaplast has got very good grip, so it lasts for 2 to 3 days.
How long would you ask your patient to wear the tape?
I think it doesn't take more than 2 to 4 weeks to realize that it's getting cured.
Actually, we have to tell them to degrease it, because if they put some ointments, it doesn't adhere, and the spiral direction has to be shown so that they don't cause any vascular compromise. And I would go by the signal of the nail growing beyond the end of the lateral nail fold.
Hyponychium.
Long enough, hyponychium. Yes. So only then I'll tell them to stop doing it.
So Dynaplast is one particular material which is being recommended. Any other materials that you may found useful in your patients?
I do only one. I generally try to keep my life simple.
You can double fix it, like put a Dynaplast, then in the at a 90-degree angle, you can put 2 small Dynaplast to fix the ends. So that will give more grip, and that can be kept for around 4 to 5 days also.
So there is this technique described by Hiroko Arai, where they put a linear, I hope my cursor is visible. They are putting a linear piece of tape here, and then that linear piece of the tape is pulled back by another tape which encircles over the digit. And the patient should be wearing it for most part of the day. So even if it comes off, it has to be reapplied. And as rightly said by Dr. Tahiliani, sir, the nail has to grow out for permanent symptom relief, and the patient education should be a part of this method. Any other measures that any of our panelists are fond of using or have particular experience with?
The gutter splint is a useful method. Only thing is, under the gutter splint that we put, I normally use one trick. I put the splint and I fix it to the nail plate with the Fevikwik. And since you are putting it on the non-viable part, it doesn't slip out. Otherwise, invariably in 2 days, they come with the splint which just come out while they walk.
Yes,
so
yes.
Fix it well.
This is, and especially once it is like growing out, and cutting it to the proper edge is also important. The only thing is inserting the gutter splint might itself be so painful and might require anesthesia. So one school of thought is, why not the definitive procedure also under that anesthesia rather than a gutter treatment. Anybody has experience using the cotton wick or cotton pledget being inserted? Because there also it says that it should be wetted before being inserted, and the patient themselves can keep on inserting once you educate them.
The idea of all these things putting is to create a gap between the lateral nail fold and the nail plate.
Exactly.
So, and if you put anything, like even if you put the dental floss or whatever you put, it's a intervention, and it's a major, very painful intervention I've seen. So I'll better do
that can be done with topical anesthesia also. So no need to inject also. These procedures can be done with under topical anesthesia.
So we had this recent question on our NSI Facebook page. There was a query, what nail wires are available in India? Since there have been
nail braces are very difficult. I got nail braces. Actually, one of my patients got it from Mumbai. And it's very difficult to use it, like it gets loosened, then you have to, and then you can't use certain kind of footwears, and it shows on the nail what you are doing, and then it needs to be fixed or adjusted periodically, which is a very difficult task.
It can also slip out sometimes. They come with the braces also, which come out.
Yes, sir. Yeah.
So coming to our next case, a 12-year-old boy who cuts his nails too close, as you can just see, and he has pain and difficulty in walking. What will our panelists do with such a case? Suggestions, please.
Don't trim that short, let it grow.
Yeah.
Simple.
What you can do in a kid like this is just to place some acrylic nail until the nail grows to the top. It's fun. You make it blue, pink, whatever. It's fun. He's 12 years old, and you will just help the nail to grow out and press on the tip of the toe until the nail has reached a normal length. That may be useful. But he has some kind of leakage on the lateral side, and I'm not sure that he's cutting his nail so short because, yeah, exactly there, that amount some narrowing of the nail, maybe.
Yeah. So the the point of asking this question was, in a 12-year-old child, we can prolong the conservative phase rather than opting for a definitive surgical treatment, because still the whole anatomy is evolving. It's not like not highly recommended to give a star maybe at this stage.
And I think advice can be given on the proper footwear.
I agree totally, because these two
with
toes
the
are
broad
touching
front,
each other firmly.
Yeah, and open footwear maximum, but since they have to go to school, either they get a waiver or they use a shoe which is broad in the front.
So this boy grows to 15-year-old. He is now a football enthusiast, so has to wear shoes while kicking his football. School going with active lifestyle, and duration now of this disease is 4 months. What will be your preferred method? Will you still want to give a trial at 15 years of age for conservative methods? My point of asking here is, do we need to be aggressive in adolescent type of ingrown toenail?
Here, ma'am, we can do one thing. We can put a tape the way we do for the lateral part. We can put the tape from the distal end and just below. So that will also prevent the popping of the soft tissue. So that may help also.
So much of discharge coming out as can be seen. The tape is hardly, I mean, there is a problem in the tape sticking for a long period of time, enough to have a pull, a proper pull. I read in one of the articles that mastisol can be used. I'm not sure what is that. So because in such a grade 2 kind of a change, the tape might not stick effectively.
And another problem is, even if we do the surgery, the studs which they wear, they are very narrow.
Yes.
So that is so I have told many of my patients to, get customized studs made. And generally what the parents end up doing is they will get one size bigger. So again, the problem is the same. When they are kicking the ball, again, it's hitting there. So in such cases, even surgery becomes very tricky unless you ask the boy to stop playing at least football, because the shoes there cause a lot of problem.
Yeah, shoes and the repeated act of trauma.
Even the studs are very narrow. If you see the shape of studs, they are very narrow and they are very thick. They are very uncomfortable shoes.
Yes, yes. So
one could use the Dynaplast covering starting from the nail plate and going across. That way it tends to stay for a longer time, and then fix it from the side, lateral transversely also.
But Dr. Chander, I feel this is 2A. You see the lateral end, there is a granulation tissue. I doubt that the conservative management will hold for a long time in this case.
Yes, I agree with that. The point is just the age of the child, and should be how much time should we watch it with conservative methods, especially since he has cut it too small also. So if we wait, how much time do we
Recently, if I would have known that this case is going to be presented, I would have shown the pictures in 4 weeks' time. The child has done so well. He came for follow-up yesterday, and he had this, but I advised him topical cream mupirocin, or I don't remember, fusidin cream application, compresses, and let the nail plate grow. See, even he is cutting it very short. So sometimes this granulation tissue will also, because this is because of the repeated trauma, and the distal nail plate is impinging onto the lateral nail fold. So even this, I've seen this. If you keep patience, patient will also be patient, and they may do well. So I will take a chance of conservative method for a month at least.
So changing their hobbies might be traumatic for them at this age group, and doing definitive measures also at this age group might be problematic. So it's a weighted decision that we are going to take for this particular case. And if we decide to take up surgery, which one would you prefer? So we've had such a long discussion about which one would you...
Naturally, partial nail avulsion with matricectomy, there is
of course.
But how will it treat the distal embedding?
Taping until the nail grow.
Taping.
So another case, a 35-year-old businessman, he's a white-collar worker, long-standing history of flare and subsidence of pain and inflammation. It's coming and it's going. Here, the medial fold is involved and much hypertrophied. So what do we do now?
Debulking, it's a harpoon nail. What you see at the tip of the toe, there's a little papule there, and it's indeed a piece of the nail which is just going out there soon. So you just remove, simply debulking, and you will be rid of it.
And you can insert a probe and see how much it is ingrown. The plate is actually ingrown. So the matricectomy procedures, we've had discussion about the various chemicals. We've had about CO2 laser, radiofrequency. We've not covered vinograd, or we've not covered cryotherapy. What else? Which one of these? We know that operators have told us which one is their favorite, and the outcomes are the best in which you have experience. That also we know. But any other point that we would like to bring out here, especially for such a case? Here, Dr. Richert has said that debulking will be helpful. But if we need to do the matricectomy, reduce the width of the nail plate, any particular choice?
Well, we have done published a paper on comparing 100% TCA and phenol, and it shows they work the same. The advantage being that phenol is just a little bit better than TCA. The point is that phenol and TCA will just give you some post-op analgesia because they are destroying the distal nerves, which is not the case for sodium hydroxide, which is a basic liquid. And this is why I'm not very keen on doing any other type of surgery like CO2 laser. Even if it's very clear, it gives very nice result, but you induce some thermal injury. But you have to give potent painkillers because it's not anesthetic like you have with these chemical therapies. You have to know that when I'm doing debulking, I'm giving very potent painkillers because I know I'm inducing pain. So you have just to know what you're doing. And well, matricectomy with phenol and TCA is so comfortable. Patients never complain. They didn't even take one pill of painkiller. It's fantastic. That's the advantage.
Valid point brought out by Dr. Richert that with CO2 laser, radiofrequency, electrocautery, the matrix is lying in close proximity to the bone. So at least as per literature, there is an incidence of the thermal damage to the underlying bone structure and deep-seated pain. And chemical quadrant, we've had this opinion about phenol versus trichloroacetic acid, the experience with Dr. Richert. And personally speaking, I would say that sodium hydroxide has much lesser downtime as compared to the use with phenol. But phenol is one agent which is well researched. You have Cochrane database reviews available on that, and it works very well. Works very well in 95% of the cases, keeping in mind that the procedure is a blind procedure. So it's not up to the quadrant. It's actually up to the extent to which you expose the horn and apply the quadrant, whichever you choose. So going on to another case, this one is a 35-year-old male. Please see the changes in the nail. He has distal pain and discomfort in walking, distal lateral pain. And again,
onychomycosis
with formal shoes, who wears formal shoes for most of the day. How will you now go about this case? He's having pain here, you can see.
But so he's got very clear-cut onychomycosis. I can see the proximal this thing. So
onychomycosis leading on to ingrown nail in this patient. It's a differential that you have to explore every time you're seeing an ingrown dystrophic nail. And then once, yes, the patient has onychomycosis, KOH culture, everything positive, just trichophyton rubrum, what do we do?
Treat onychomycosis.
And wait for the ingrown to resolve.
Also ask him to change his shoes. He would be wearing pointed shoes.
Yeah. Again, the shoes. And again,
treatment of the shoes, changing of daily socks, cotton socks, and
like to bring out the fact which was brought out by Dr. Khushbu. Dr. Khushbu, if you would like to elaborate, the treatment of onychomycosis in fact may worsen the ingrown element. So
yes.
How many would be, and why would that happen, and how many would be in favor of treating with matricectomy also, right in the first one? Opinions invited.
Never saw onychomycosis worsening, leading to, so maybe yet to see.
We can thin out the nail plate in the middle, and along with on a treatment for fungal infection, so that will flatten the nail. This will never worsen. If you thin out the center part, middle part of the nail,
debridement might help. Exactly, debridement might help, because starting antifungal treatment is not going to relieve the patient's pain, the difficulty with which he has come, and in changing his shoes and all that will help in the long term. But in the short term, one approach could be debridement, and the other approach could be opting for the surgical procedure in case the pain is significant enough. It will depend on individual case to case. But onychomycosis is a very important thing which you need to rule out. Another patient with lateral matrix horn resection, once you are doing for this patient, that is the procedure that is being done. And what do you do for this granulation tissue, or would you call it a pyogenic granuloma? What do you do with this? Do you touch it, or do you leave it for resolution on its own?
When you do phenol matricectomy, it's automatically phenol, gets phenolized.
So when
even if you are using a CO2 laser, you treat it simultaneously.
Yeah, and if you're doing RF, you just put a probe on it.
Yeah, RF or maybe cautery also.
With even for phenolization, even while doing phenol matricectomy, your phenol will definitely touch the granulation tissue.
The procedure of the chemical cauterization of the lateral matrix horn, we try and avoid touching the folds as far as possible, because the more amount we use, the more is likely to be the post-operative ooze. So the nail fold and the nail bed, we avoid touching. But in this case, as Dr. Archana ma'am is saying, we should touch this area specifically so that it resolves faster and does not contribute to the ooze which is going on. If it is a well-defined pyogenic granuloma, then all the more reason for opting for whatever treatments you find comfortable in your hands for pyogenic granuloma. So that post-operative outcome. But granulation tissue per se need not be touched every time, because it resolves very fast as soon as the nail plate is, the inciting nail plate is taken away.
I totally agree. It resolves by itself, and if one has to do, even without any cautery, if you have a curette that you're using as for check curette, you can just curette it out or just cut with the sharp scissors, because you have done hemostasis, it doesn't bleed.
Yeah.
Only thing you have to be sure it doesn't ooze, because if it does ooze and then you put phenol, it will get neutralized and it won't do any job of matricectomy.
Exactly. I totally also agree that phenol would definitely, if we put it on this lateral gutter, definitely there is a lot of ooze, and sometimes if it is too much, then it can cause a tissue necrosis also, and it is known with phenol.
And anyways, whatever amount of tissue you cauterize, it is going to prolong the post-operative discharge. But this one is a proper pyogenic granuloma as compared to the previous granulation. This is an organized thing. So
I would do RF.
The nail is cut too short, much too short. That's why the corner especially is rubbing against the second toe and is inducing this. It's not pyogenic granuloma for me. It's just also
granulation tissue, hypertrophic.
We can do RF in this.
Yes.
Radiofrequency.
So post-op management, how many of you prescribe antibiotics routinely?
Well, I also give antibiotics routinely. There is always two schools of thoughts, but I always prefer giving antibiotics because it's the leg.
Do you have any other?
I have, if it is clean and there's no secondary infection, I have stopped giving antibiotics, and it does not make any difference, because if they take good local care, even locally, one can use simple paraffin and not any antibiotic ointment.
Okay. Yeah, I totally agree with Dr. Sushil. I told him my talk also that if it is clean, no need for antibiotics. At least I don't give.
So
I only use antibiotics when I'm working on the bone. I never give antibiotics unless it seems infected. Otherwise, when you use phenol kills any germs. TCA kills any germs. So if you're doing a surgery properly, well, usually a Vaseline will do the job. And if you ask your patient just to do the soakings and so on, and it works very nicely, unless it comes infected afterwards. But I never give antibiotics routinely.
So I use antibiotics routinely, and even though lack of literature to support based on Cochrane database, but otherwise you have enough in literature to say that it is a clean contaminated surgery, because it's all with your best sterilized equipments and best sterilized OT. The nail fold itself is harboring a number of organisms, and not to land up in scenarios like this, which tend to occur in our tropical.
And you know, the kind of hygiene our patients have. So it depends on what you are.
Yeah. So
maybe
you are catering to,
is important.
whom you are catering to.
Yes.
So
yes. Ma'am, you were saying something?
No, like if somebody, like I'm doing it during these rainy season, and you know, patients are walking bare feet, everybody doesn't travel in car. So sometimes it becomes essential.
Many of them are laborers or
yeah. So you know, we cater to a different set of patients altogether.
Yes. So coming to the next, post-operative management, dressing schedule. How much frequent change of dressing do you advise? Because obviously this is going to be different for the lateral matricectomy surgery versus the nail fold surgeries, which Dr. Richert demonstrated. So what kind of a dressing schedule do you advise, Dr. Richert, once you've done that extensive debulking?
I ask them just to wash their feet. Well, I just put first a dressing for 2 days. I leave the dressing for today, and I change the first dressing myself, and I show them on how to do the dressing themselves. That's teaching, first thing. And then I ask them to renew the dressing twice per day and go in the shower with their dressing, which gets wet, so easily removed, and to clean it with soap and water, just to get rid of any biofilm that may be there, and just put some antiseptic ointment on top. But at least when you ask them to do that twice per day, they will do it once. That's as usual. But for those who are doing it twice per day, you shorten a bit the oozing, because they really clean out all the scabs and the oozing, and it dries off a bit faster.
Okay.
For chemical matricectomy, of course.
Only when we tell them to wash with water in India, we tell them to use AquaGuard water or bottled water, because there will be water which will be contaminated. And therefore, we have to be careful about giving that a bit of advice.
Yes. Okay. So moving on to our next case, a 25-year-old lady with bilateral involvement, both toes involved. I know Dr. Richert's answer. Can I have can I have any other opinions? How would we want to manage this?
Probably this will need both the lateral nail fold trimming and trimming the nail plate, because nail plate also appears to be big. Here you have to combine the two.
Yeah, it'll need a combination probably. And this whole whitish discoloration in this area, probably there is a lot of pus tracking in this area as well. But surprisingly, the patient does not have much pain. So, I mean, how do we explain such a discordance between the signs and symptoms in ingrown nail?
It's really amazing when you have those people with chronic ingrowing, because that's been lasting for a long time. When it becomes chronic, there is almost no more pain, even if it looks terrible. And sometimes they have a very tiny ingrowing at the beginning, which is acute, which is extremely painful. It's completely different.
It's completely different. So you have to take both the cues in mind while deciding the treatment option for your patient. Such signs definitely need to be treated, but pain, significant pain, which is compromising the activities, also needs to be treated, even if more significant signs are not present. So this would have been Dr. Richert's answer, which he has already demonstrated well. One more question is, we often get such patients. So do you operate both the medial and lateral involvement at the same time? And do you operate both the great toenails at the same time? So like, am I going to do 4 surgeries for this patient in one day?
Many times I have done this, all the sides in one sitting only.
All the sides in one sitting. So 4 different local nail matrix phenolization. Anybody else has any different approach?
I do one toenail, one session. So both the sides, but one toenail.
Same here. I would one toenail, the more affected one, maybe the one which is visibly more affected or which is more painful. And if yes, why? And if no, why not? Dr. Soni now has to answer. Why?
If the patient has difficulty taking leave each time, then I can do all the 4 and tell them to take rest and get done with the problem once and for all.
He's anyway going to, with us, going to take antibiotic also. So
the advantage is you need to give one course of antibiotic. For such a case, we would need antibiotic, whatever the scenario might be. But then I generally don't do, I had done both in some cases and the patient was so uncomfortable. So they said, you know, had you told us, we would have taken leave twice. So I don't do it.
Yes, same for me, because it's easier to manage one toe with a bulky dressing, both toes with a bulky dressing. Even going to the bathroom at times is difficult for the patient. So keeping that in mind, I prefer to do one toe at one time, but there is no absolute, there are no absolutes here. Another question, in case of a unilateral symptomatology, this side, no pain here, the nail is also outgrowing, but you can still see changes. What will you do? Nothing here, just say, but there is onychophosis which is already developed, some amount of discharge, patient is not symptomatic. So will I operate both the sides?
I would definitely.
Definitely both the sides. And suppose if this onychophosis is also not present, and because there is a paper, there is a research study which says that once you start operating on one side, then the nail starts going. Yeah, there is a deviation. There may be improvement. Of time. So does that really happen? I mean, should we be worried about operating on one side and not the other side?
I don't think deviation is a major problem.
I always prefer to go for both the sides for that reason. I always prefer both the sides.
Okay. Now coming to the other type of ingrown, the distal ingrown, how often do you encounter this and what are the common causes in your practice? Then we'll move on to how we manage distal ingrown.
It's not
distal embedding means, you mean distal embedding?
Distal embedding.
That's quite often if patient removes or somebody has manually removed the nail plate without lateral matricectomy.
Generally done by surgeons.
Yeah.
And patients land up with us with distal ingrown. Yeah. And over a period of time, even the lateral ingrown, as can be seen in this case. Yes. So what do you advise to your patients? Like this bilateral distal ingrown.
Patients always prefer conservative, but I have done in such cases the trimming of the pulp of the flesh, the debulking of the tissue.
Debulking of the tissue.
Yes, I have done, because when nothing else works, debulking does work.
And what about? Yes, please.
You can do a Dubois there. So just a crescent of flesh to pull down this, pulling up distal bed. So you will pull it down by stitching. And that's the only way to get this bed spread distally.
Right. So basically, as you can see, a lot of inflammation in the distal nail fold. Here, you may be prompted to take up the operative intervention. But personally speaking, for cases with distal ingrown, I prefer to give them, a long leash with respect to the conservative management. I'll give them a longer trial of conservative management than I would give it to a lateral ingrown, and then decide the outcomes later on. Because you're dealing with even if we remove a part of the nail plate, it is again going to come back to that same level.
I have tried acrylic nail, but my complaint is most of the times the acrylic nail comes off because the part which is hanging out, it's not very stable. Somehow or other, they come and tell you that after 2 or 3 weeks it came off.
Yeah, the acrylic nail actually needs a proper base to be built upon. That is why if the nail, like in the previous image, if it is so much absent, then the acrylic does not hold on, as you are pointing out, sir.
I'm trying to provoke Soni into giving her comments since she is an expert.
Sir, a small acrylic nail would work if we have a very long. So, you have the underlying nail plate and just maybe a 2 millimeter beyond that would stay. But if we try to give an acrylic nail for the normal shape, then that would not stay.
But without normal shape, it will not serve the purpose. No, you have to push back the...
So, exactly. So in this case, I have not found acrylics to be very useful in such cases.
So the distal massaging and the distal taping, they work better in such a scenario. One more important thing which keeps on happening is this distal piling up of the nail plate. Because it is not growing, as you can see, it starts becoming thicker and thicker towards the distal end, and again becomes more difficult to manage. Now, a 27-year-old female who's an active jogger and has this problem for 6 to 8 months. What do we do?
Well, you have no choice. She has a pincer nail. It's triangle nail. So you have just to phenolize both lateral sides as fast. So she will get a narrow nail, but she will have something which is comfortable for jogging.
So, yeah, but because the inflammation is localized here, the whole proximal nail fold is involved. Do we consider Retronychia? Even though the xanthonychia has not yet developed, the thickening is not there. But
because you should start with stop of the growing of the nail, then xanthonychia, then the granulation tissue. Here you have some inflammation and granulation tissue. The question is, does your nail grows out still? And see if there is some yellow discoloration, which doesn't seem to be the case. But if you look at how she's trimming a nail, she's really making the nail trim even on the second toe. So for me, it's ingrained pincer nail. It's nothing to do with Retronychia.
And another case of a 24-year-old beautician with pain, discoloration, and thickening of the right.
This is frank Retronychia.
Deep-seated pain, pus discharge off and on, with slow growth of the nail. So etiological factors we have discussed. Dr. Michela's talk, we have seen so many etiological factors which were highlighted. And this case being so far advanced, I'm sure the conservative methods may not work that well in this particular scenario. And she had to undergo total nail avulsion for this, and it was totally impacted at both the ends. So moving on to one more case here, which remained a dilemma for me. It was a distally thicker nail, and the patient kept complaining of severe pain in the distal end with the fact that he was not having to cut his nail for so long. The nail was not growing was the complaint. And what should we suspect and how to manage such a case? There was severe pain at the distal end, distal nail fold. And you can see the thickening and you can see the discoloration at the distal end. The proximal nail fold is normal. Lateral nail folds also do not show. This is ultrasound jelly, which is applied, the transparent thing that you are seeing. So the patient had not cut for a long period of time. It did not just grow. So what should we think and what should be done for such a case?
I think you should think, because if the patient is not cutting the nail for a long time, it means that there is rubbing against the shoe, and you should look for a podologic, a podiatric issue, and most probably there's rubbing.
Yeah, this like we got an ultrasound also done. So the only abnormality which we could detect even on like after ultrasound and X-ray and even getting a QH done was a spur which was present at the end of the distal phalanx. Spur which could possibly be explaining causing an obstruction to this part of the nail plate to grow further and causing a heaping up of the nail plate in this area. So has anybody encountered such a scenario? Would we call it a distal ingrown?
Interesting.
This would be distal ingrown only.
because of the heaping, which is occurring slightly.
Definitely.
And the cause here was probably something, again, an active boy who was like playing around and an athlete, and probably a distal spur which was present on ultrasound was responsible for his pain and his difficulty. And I classified it ultimately as distal ingrown only, though it doesn't fit the classical scenario. So another 18-year-old schoolboy with distal pain and raised and curved nail. What investigations would you want to do? I mean, that's a clue. I'm sorry.
Is it
bony anomaly has to be ruled out?
Yes.
Subungual exostosis.
Exostosis, again a differential which needs to be ruled out, because on looking at the dorsum you may not think this looks like an ingrown, but this area, if you see carefully and on end-on examination, it is visible, and on X-ray also it is visible. So subungual exostosis is another condition which can be painful and which can cause curving of the nail plate, needs to be ruled out before you are planning treatment for your cases with ingrown nail. Now, this is a 30-year-old doctor colleague, previously operated ingrown. Now, after a few years, I mean, you can see the previously operated ingrown and its scars. Now there is no pain, but the nail plate is very dystrophic, thickened, and the second one is also getting involved.
This looks like onychomycosis again.
Yeah.
Again. So it was a total nail avulsion done by a general surgeon, and you can see the shrinking of the nail bed and the distal nail fold hypertrophy and the scarring of the lateral nail fold, which has occurred over a period of time because the nail was totally removed. And after that, the nail plate, the regrowing nail plate has become infected, and now a kind of a chronic condition has developed. So with this scarred nail plate, it is difficult to give a very good cosmetic outcome.
I totally agree. These are cases which are very difficult.
Yeah. 45.
Don't you think it might be just a congenital malignant that was treated by avulsion, because there is some little malignant, and the disappearing of the bed it might have been a congenital malignant that was treated by avulsion?
Yes, it could be a scenario of congenital malalignment also. Thank you for pointing that out. Again, seeing the axis of the nail plate as compared to the rest of the phalanx. And if not operated too early, let's say by 2 years of age, and corrected surgically the matrix alignment, then this outcome is very likely, and secondary infection has also occurred. Going on to the next case, 45-year-old diabetic with a slow progressive condition, no symptoms. Does it need intervention?
No.
No. I would also like to treat, not to treat, though it is a clear-cut pincer nail pinching up the nail bed, but there are no symptoms. So we'd like to give general advice and conservative measures for this patient. But if a patient has multiple pincer nails and symptomatic, then what does the house say? What could be the causes? Again, a diabetic. Again, a diabetic. Not very.
If it is symptomatic, one has to try and do something, because if it is painful, you can't tell them that there are too many to be, because we just saw Dr. Richert showing surgery on 4 and 5 toes on the same day.
Yes, yes.
We should go to Belgium.
We'd like to rule out onychomycosis, and we'd like to rule out exostosis also before going in for surgery. How often do you see exostosis in pincer nail?
We have done study on X-ray, and we published that this is not so frequent, something like 10 to 15% of all pincer nails.
And more often it's a traction osteophyte, as Dr. Tahiliani showed us, and how it has to be managed. Now this,
the previous one was like the tile nail, it was a pincer nail where the edges were parallel. The one before this. Yeah. That's called a tile
diabetic
nail.
one.
Yeah.
This one. Yeah.
So the edges are not converging.
So, and now another patient, again multiple pincer nails, again a diabetic. But the interesting thing is The symptomatic ones are the thumbnails. What do you do? She doesn't have symptoms in her toenails, but her thumbnails are a problem for her. And
See,
they are
these cases are very common in our setting. I don't know how and why. Maybe we have more diabetic population visiting our hospital because of the institute, diabetic institute. But this is very common, and sometimes I really dread taking them up for surgery. And application of keratolytic cream like 20% urea, softening them, have works really well for my patients. If my nails are involved, even for toenails, I've done that, and it has really worked.
What preparations do you advise, ma'am? Which percentage and what
20%. I haven't used 40% because it's never available, but 20% ureative cream is available, and it works really well.
Now we have 40% also.
Yeah, it is there, but since 1.5 years, we are not really seeing patients, because our hospital was full COVID facility and it has become available during that period. So what I was doing was I was asking them to put micro pore first, exposing only the area where the 20% urea is to be applied. Then I ask them to apply. I show them how to do it, and then put another microwave. So that's kind of occlusion, but it doesn't cause maceration in the surrounding skin. I asked them to keep overnight, and it has really worked, shown very good results in about 4 to 6 weeks.
I have started asking about a history of which antihypertensives they take after having seen the association between beta blockers and pincer nails.
Yeah. Right. Again, because of the peripheral ischemia.
Yeah.
Yes,
when you stop beta
because
blockers,
diabetics mostly have peripheral ischemia, and is one of the reasons for developing pincer nails in multiple. And of late, since we have a very big institute associated with our hospital, we see a lot of these cases.
I didn't get you, ma'am. You put first the tape,
micropore in the surrounding area, in the hyponychium, lateral nail fold, and the proximal nail fold. Only the nail plate is exposed. Then I apply I used to do it for the plantar callosities and all.
Okay, right.
Rather than putting
another one to occlude it. Yeah.
Okay, so this case answers 2 of the questions from the audience. One, why is ingrown nail uncommon on the thumbnails, and why? Yes, it is uncommon, but it can rarely occur. And why? Because thumbs are not are not bearing the weight of the body.
Dependent position.
The biomechanics are not there, and they are not occluded in a constricted space, unlike the toes. Because it says that prior to the shoe wearing started, there was practically no problem. It has started with the footwear. Probably. Then there were questions: how frequently should the dynaplast be changed by the patient? We have discussed that. How to distinguish malalignment of great toenails from retronychia, and what is the approach for malalignment, managing malalignment of great toenails? We have not discussed malalignment today because it's a separate topic, large topic in itself. But how to distinguish from retronychia, if any of the panelists would like to. Sir, Dr. Richert, would you like to say?
Difference between retronychia and?
Congenital malalignment of great toenail.
Well, it's hard to answer because what we have as a trigger for retronychia might be congenital malignant in some instances, which is minor forms where the nail is a bit displaced and that might just not absorb the trauma properly. So that might be a trigger for a retronychia. But normally, retronychia is a nail which is normally aligned, which is a normal thickness of nail, which is yellowish, and you have inflammation of the base. It's something which is acute. Congenital malalignment is something which is non-painful. The nail is malaligned, the nail is thickened, it has abnormality on the surface, and there is no inflammation of the proximal fold.
Right, thank you. How many ml of lignocaine can be safely used per nail? For proximal block, we use anywhere between 3 to 4 ml per digit, not per nail. And What is done with the granulation tissue? We have discussed that. I thank Dr. Bertrand for a very interesting presentation. Thank you, sir. Pyogenic granuloma has increased in lockdown protocol. We have discussed the protocol for that also. We come back to the question of pregnant females. Which procedure would you like to do in case they have ingrown nail? Now we can have more panelists answering.
Well, you can
conservative. Yes, Dr. Bertrand.
Go ahead, Sushil.
Yeah, please. I'm very keen to know your approach with strict rules over there.
In that you can use, of course, a CO2 laser in pregnant women. Of course, if you protect their eye and the belly is very far from the toe, there's no problem. And well, you can use chemical too, because it's it's just one drop. Of course, it's not recommended to use it in pregnant women, but when it's painful and she don't treat a growing nail and the pregnancy is going on, she will be bigger and bigger and fatter and getting more and more weight in that toenail, and that would be very painful. So I'm very keen to do that. It's just one drop of phenol, of one drop of TCA. If you're worried, TCA is very fine, and you get rid of this ingrained toenail. And it's very important to heal this ingrained toenail before the end of pregnancy, because otherwise it's a mess. And I was amazed because no one of you proposed, but I think it's because it's India, but we're using a lot of steroids for inflammatory nail disorders, especially in ingrained nails. Well, people are not walking barefoot in our countries. So, and when you have an inflammation of a beginning of ingrained nail, we tape them, we make occlusion with steroids, and sometimes it helps to resolve the granulation tissue and even heal completely a very beginning of ingrained toenail.
I have sometimes used intralesional because when you use them topical, they tend to overuse and misuse it.
Good idea.
Yeah.
And how much time plastic tube is to be kept and how to be removed? It grows out with the growing nail. That is the aim of the procedure. Can pincer nails be managed along the same lines as ingrown toenails? Broadly, yes, as Dr. Sushil Tahilaini has pointed out already, except for the fact that you have to add another step. And I guess this covers, and questions about urea, which Dr. Archana ma'am has answered. And that's it. These were the broad questions which were there. So I thank all my panelists for the valuable inputs which they have given for this presentation. And if there are no more questions, then I will just, sir, any comments? Otherwise, I'll move to the closing remarks because we are already 15 minutes over our designated time.
Yeah, it's Saturday.
It's Saturday. So just the closing remarks. Is my screen visible? Yeah, I would request all of you to become members of Nail Society of India. We've had close to 350 attendees today, and they can join this 390 member strong community and help us grow further. Please visit our website. There is Join NSI, and you download the membership form and join us. And we are also going to be conducting our annual national conference again in an e-format this year on 13th and 14th November 2021, as already announced by Dr. Sushil Tahilaini, sir. And looking forward to having you all there and keep on learning more and more.
Thank you very much.
Thank you very much.
Thank you so much.
Thank you. Thank you.
Thank you. So now we officially close the session. Thank you.